Well, good morning. We're coming to you live from Martin Center Sickle Cell Initiative in Indianapolis, Indiana. It's September 25th, and it's time for Martin Center's 2020 Indiana Sickle Cell Conference virtual edition. I'm Gary Gibson, President and CEO of MCSCI. And on behalf of everyone on our team and everyone in our family, let me say that we are happy to have you here with us today. This is our first ever virtual conference, and we're excited to offer you a unique program that will be filled with important, timely information about sickle cell trait, sponsor acknowledgments, and of course, your participation. Here's how you can participate. We ask you to please use the chat function to pose any questions that you might have for our speakers as they do their presentations. We will try to get to as many of them as time allows. We ask you to please use that function sparingly and carefully. That's all there is to it. So let's get on with the activities, and we'll start with an acknowledgement of our sponsors and then a short program before we begin our presentations. So hold on, please. Start the video. Go into the three dots. Let's say stop video. We're very happy today that we have 4 outstanding speakers to present information about sickle cell trait in today's conference. Our speakers are Dr. Rahki Naik from Johns Hopkins Medicine, Dr. Michelle Owens from the University of Mississippi Medical Center, Dr. Joel Jaeger, with Major Health Partners Sports Medicine, and Dr. Mary Hulihan from the Centers for Disease Control and Prevention. Please bear with us. This is the first ever virtual conference.
Thank you to our sponsors, Marion County Public Health Department, Emmaus, Community Health Network, GBT, Indiana Hemophilia and Thrombosis Center, and IMHC, and then also American Red Cross. Don't freak out. Okay.
Hello, I'm Dr. Virginia Kane, Director and Chief Medical Officer of Marion County Public Health Department. I am here with two special friends, Alexandria and Audrey. The coronavirus of COVID-19 is real. It is affecting our community and our young people every day. It is important that you watch out for your loved ones and yourself. You hear a lot about myths, but let me tell you, COVID-19 is real. Rise above the myths, elevate your mind, and choose life, not death. Life is the way to go. Think twice and act once. This is real. Remember to social distance yourself 6 feet. Stay at home. Wash your hands frequently. Cover your coughs and sneeze. Clean and disinfect touch surfaces. Wear a mask in public. This is real. Remember, COVID-19 is real. Rise above the myths and reduce the spread.
The Indiana Hemophilia and Thrombosis Center, IHTC, began with a vision for a center where patients and families affected by blood disorders could receive the best treatment. With extensive experience in hematologic disorders and depths of specialization in the field, IHTC's doctors, nurses, and specialists are focused on improving quality of life for our blood disorder patients and their families. IHTC is committed to providing the highest quality comprehensive services and holistic care to patients with bleeding, clotting, and other hematologic disorders to their families. IHTC's vision is a future where people with rare blood disorders flourish. IHTC delivers patient and family-centered, comprehensive care for hemophilia, thrombosis, von Willebrand disease, sickle cell disease, and other bleeding and clotting disorders, including rare conditions. IHTC values innovation, high quality, teamwork, and compassion. In short, IHTC values you. For more information about IHTC, visit their website at ihtc.org.
Hello, I'm Dr. Tetlock, President and Chief Executive Officer of Global Blood Therapeutics. Since its inception, CBT has focused exclusively on sickle cell disease. For too long, treatment options for patients with sickle cell have been limited. We are thrilled that just recently the FDA approved Oxbryta for the treatment of sickle cell patients 12 and over. The approval of Oxbryta
I sent
was
everybody.
years of collaboration.
He's the new board member.
If it wasn't for the
I sent
ongoing
everybody.
partnership
I sent everybody.
and unwavering dedication and innovation, I just cannot. So I really want to thank you. This simply could not have been done without your support. As we enter this new chapter, GPT remains committed to working with patients, families, and you, the community, to ensure access to Oxbryta. We will also continue working on finding the next breakthroughs for sickle cell disease. We won't stop because sickle cell is a well-managed chronic disease with oral effects. And I'm confident that we can achieve that goal.
Having severe chest pains and but it's still up to you the choice on whether or not to follow up and get it properly diagnosed in the middle of the pandemic or
I wish I knew if the animals can see. That's a bad, that's
has the infection on, and I was treated for something that had to be treated.
Yeah.
Or identified.
So one person.
Let me just message somebody.
Where are you seeing people?
I can lift that here. Somebody else. So let me
And DAR is an amino acid indicated to reduce acute complications in sickle cell disease in adults and pediatric patients 5 years of age and older. We would like to congratulate the Owens to the 2020 Indiana Sickle Cell Conference. The DAR stands with you and supporting and treating sickle cell patients. Thank you for your continued leadership.
In 1992, local minority health coalitions throughout Indiana were inspired to start addressing the health disparities among Indiana residents. With the help of the Indiana Black Legislative Caucus, they collaborated to develop the first 5-year minority health strategic plan for Indiana. As a result, these local coalitions were able to create the Indiana Minority Health Coalition to facilitate the adoption of the strategic plan as it passed through the legislative process. Maintaining a healthy lifestyle is the key to ensuring that we all are able to live productive lives. With health and longevity, we are better able to make the most of our relationships with family and friends. However, we know it's difficult to adopt the healthy habits that can help us minimize our risk for heart disease, obesity, diabetes, and other health conditions that can inhibit our ability to lead long, productive lives. That's why the Indiana Minority Health Coalition is dedicated to helping you. IMHC's programs, research, educational sessions, screenings are more at your service to ensure the best possible health for you and your family. For more information on IMHC, visit them online at imhc.org.
Sickle cell disease is a lifelong condition. Blood transfusions can offer a lifetime of hope. Sickle cell affects up to 100,000 people in the U.S., and many need blood, sometimes up to 100 transfusions a year. Blood donors like you make a difference in treating this serious blood disease. Blood donors of all ethnic backgrounds are needed so we can find the best match for patients. Roll up your sleeves and help someone in need just by giving what you have to give. Make your appointment to give blood at redcrossblood.org or 1-800-RED-CROSS.
And now, please stay tuned for an important message from Martin Center Sickle Cell Initiative.
Hi, I'm Miracle. I'm 13, and I happen to be the youth ambassador for Renal Center Sickle Cell Initiative. I like Renal Center because it's the only place I get to take a break from the world that doesn't understand me. As youth ambassador, I want to ask you to help me help others' life. Thank you for your support, and I hope to see you around.
Well, we hope that you've enjoyed a little bit of the presentation so far. We're getting close to the time when we are going to be introducing our first speaker, Dr. Rahki Naik. Dr. Naik is with Johns Hopkins Medicine, and she also seems to know a whole lot about sickle cell trait, and we're extremely happy to have her with us. And there she is now. Hi, Dr. Naik. How are you? Okay.
Sorry, I was muted.
Okay, so great. Good to see you. Just a moment, and we'll get going here. Again, we want to thank you for taking the time to be with us today. And we're very, very happy that you are with us. And you can correct me if I say anything wrong, but I'm going to just do a little bit of an overview of you and who you are for our audience. Dr. Naik runs the Rahki Naik Lab and studies sickle cell disease. Her lab focuses on complications related to sickle cell disease, including chronic kidney disease and venous thromboembolism. By defining the risk and factors for diseases related to the sickle cell trait, Dr. Naik hopes to improve genetic counseling and screening and treatment recommendations. Other research in the lab examines the epidemiology and unique mechanisms of thrombosis in patients with hemoglobin disorders. Is all that correct?
Yep, that's perfect.
Okay. Well, we think you're perfect, and we thank you so much for being with us. And we're extremely grateful that you've taken time out of your important work to speak with us today. And it's now my pleasure to introduce everyone out in the audience to Dr. Rahki Naik.
Do you want me to start?
Yes, I want you to start.
Okay, so I'll share my slides and let's see. Tell me if this works okay. Fun.
Yes, it's working.
No, okay, perfect. All right, so hopefully you guys can see all of this. Are we live to the audience now?
Yes, we are.
Okay, perfect. All right, well, thank you guys and the organizers for allowing me to talk about one of the topics that is most passionate for me, which is sickle cell trait. And what my talk is entitled is a current state of sickle cell trait. And I'll just be talking about the current data on sickle cell trait and implications for reproductive counseling. You can't see the slides moving, can you? Sorry about that. All right. So I'm going to start off with a case presentation first. So there is a couple. Both of them are 28 years old, and along with their first newborn infant, they present to their pediatrician's office to discuss the results of the newborn screening tests. The pediatrician tells the couple that their newborn daughter has sickle cell anemia. But in fact, the couple is shocked as they were completely unaware that their child was even at risk for sickle cell disease. And they frantically start asking about what this information means for themselves and for the health of their child. So interestingly, the mother stated that she knew that she had sickle cell trait, but she had been told in the past that it was absolutely nothing to worry about. And so she didn't even know about the reproductive implications of this. So how should the pediatrician counsel her about both the reproductive and clinical implications of sickle cell trait? Now, in order for us to really talk about sickle cell trait, we need to understand the global burden of it. Now, as many in the audience know, sickle cell trait is one of the most common hemoglobin mutations worldwide. And in fact, it affects about 300 million individuals in the world. And the reason why sickle cell trait has persisted to this degree in the world is because it confers an amazing protection against severe infection with P. falciparum. And P. falciparum is also known as malaria. So if you look here at the graph on the right, this is a study that was done to show where does sickle cell trait exist, that's here in the red, and where does malaria exist in the world, that's here down here in the green. And you can see that the sickle cell trait exists are exactly the same regions where malaria exists. And this just shows that in the areas where there is a lot of malarial endemicity, sickle cell trait exists in those regions. Now, evolution really cares about two things. One, that you were born, and two, that you make it to the age of being able to have children or childbearing age. And sickle cell trait allows you to, if you're in a malaria endemic region, to make it through childhood because it prevents against death with malaria. So so as you can see right here, sub-Saharan Africa is where sickle cell trait exists in the highest prevalence. And in those regions, really, it can exceed about 25% of the population can have sickle cell trait. But here in the United States, this is much less prevalent. So about 1 in 12 Black Americans have sickle cell trait, or about 8% of the Black American population here. That equates to about 3.1 million individuals. But sickle cell trait does not exist only among Black Americans. It's actually in Hispanic Americans, in white Americans, and also in Indian Americans like me. And you can see that the prevalence there, though, is to a lesser degree. So about 1 in 140 Hispanic Americans and about 1 in 300 white Americans. So now switching gears to sickle cell disease. So sickle cell trait we talked about confers protection against malaria. But what happens when you inherit 2 sickle cell trait alleles and get sickle cell disease? Well, sickle cell disease is one of the most common monogenic disorders in the world. And in the world, it affects much less than sickle cell trait, so about 300,000 births per year. And of course, that's less than sickle cell trait, which is about 300 million. In low resource regions, so for example, in sub-Saharan Africa, in some parts of the world where there isn't as much medical care, the mortality for children who have sickle cell disease who are less than 5 years is as high as 90%. So very few of these individuals are making it all the way to adulthood. But in the United States, thankfully, because of some advances, that demographics is completely different. So about 1 in 365 Black Americans will have sickle cell disease. That's about 100,000 individuals here in the United States. But about 90% of children now make it all the way to adulthood. Now, that being said, even though they make it to adulthood, the life expectancy is about 50 to 60 years. So that's about 2 decades less than the average here in the United States. So there's still a lot of morbidity and mortality associated with sickle cell disease. Now, why do we talk about sickle cell trait as a unique carrier state? What makes it different than other types of carrier states? So one thing we talk about, for example, is cystic fibrosis. Why is it different than just holding a carrier trait for cystic fibrosis? Well, the reason why is because sickle cell trait is very prevalent. So as I mentioned before, there are some parts of the world where sickle cell trait can exist to greater than 25%. That's unlike any other carrier state. And here in the United States, even 8 to 10% of the population have it, also very prevalent. And because it's very prevalent, it has a lot of implications reproductively. So because so many people have sickle cell trait, it's more likely that 2 individuals who have sickle cell trait will come together and then ultimately may be at risk for having a child with sickle cell disease. And the other reason why sickle cell trait is really unique is because unlike any other carrier state, it has been associated with some complications. And some of those clinical complications can be severe and rare, like having exertional injury with exercise, or are more common, like chronic kidney disease, and can happen in a lot of adults. And so because of that, there are some very unique challenges in terms of making sure that individuals know about their sickle cell trait and risks for certain things. And in fact, there was an op-ed piece in JAMA back in 2014, which said, you know, sickle cell trait really is a neglected opportunity here in the United States. We're screening for individuals who have sickle cell trait, yet we're not counseling everybody and using that genetic information to its full advantage. So what can we do to do that? So we'll talk first about reproductive counseling. So if you remember, going back to that first case, there was an individual who knew she had sickle cell trait, yet wasn't even aware that she would be at risk for having a child with sickle cell disease. So what can we do to improve that? Well, the first thing is to educate and empower our patients. So we can educate sickle cell trait carriers about their chances of having a child with sickle cell disease. And we can also empower our sickle cell trait carrier mothers and fathers to make informed reproductive choices. How can we do this? There's 3 ways in which this can happen. One of them is to use our existing infrastructure in newborn screening to try to notify individuals with sickle cell trait about their carrier status. So although it is happening and we're screening for it, sometimes that information is not ultimately getting to the person who has trait. Another way to accomplish this would be to do mass education campaigns, and there are certainly many of those that exist in the United States to try and educate individuals about their potential risk or get them screened for sickle cell trait. And another thing we can do is to target individuals who are pregnant. So either prior to pregnancy or during pregnancy to screen them for sickle cell trait, and then to do pre and post-conception counseling to inform them about their risks of having a child with sickle cell disease, and potentially even intervening to see what they can do to change that risk. So let's just switch. I'm going to talk specifically about newborn screening programs in this talk. I'll talk about the newborn screening programs that exist here in the United States. So the primary goal of newborn screening programs is to identify individuals with sickle cell disease. It really is not to identify individuals with sickle cell trait. That isn't the reason why it was first instituted. And the reason why there was a push to have newborn screening is so children who are born with sickle cell disease know about their disease up front, and that we as hematologists can do interventions to try and prevent them from having an early death. But a byproduct of having this newborn screening program is that we will also identify individuals who have sickle cell trait. But again, as I mentioned, this is only a byproduct and was not the primary reason for instituting this. Because it's only a byproduct, there's been a lot of barriers to notification of carriers using this newborn screening program. The number one problem is that there is not enough funding. So all of the funding has been put into how do we notify sickle cell disease, parents of sickle cell disease patients, notifying the actual children themselves, but not much funding has been allocated to telling individuals that they have sickle cell trait. The other problem with notification of carriers for newborn screening is that with sickle cell trait, when you're a child, it probably does not affect you that you have sickle cell trait. It's only later as an adult when you're planning a family, or later as an adult when you're at risk for these potential complications where it really matters. So part of what we need to do is notify individuals, not only when they're first born, which is during newborn screening, but then later as they hit reproductive age. So just by history of the newborn screening program here in the United States, so in 1986, there was a sentinel trial. It was known as the PROPS trial, or the prophylaxis with oral penicillin in sickle cell disease. What they found is that if they give oral penicillin to children who have sickle cell disease, they are much less likely to die of pneumococcal infection, which was a major cause of mortality. In fact, this trial was stopped early because it showed such an advantage of prophylaxis. So after that, they recognized that we need to know every individual in the United States who is born with sickle cell disease, because we can do something about it to change their ultimate mortality trajectory. So in 1987, the NIH had a consensus recommendation that every state should have newborn screening. So one thing I want you to note is that in 1987, those individuals are about 33 years old right now. So if anybody was older than 33 years old, they would never have even been through the newborn screening program here in the United States. But you can see right here at the graph on the right, there were very few states that really had newborn screening before this consensus recommendation. Once a consensus recommendation was put into place, every single state started to introduce newborn screening. And then the last one here in 2006 was New Hampshire, the last state to adopt newborn screening. So again, if you're born in New Hampshire before 2006, you would not have known your sickle cell trait status. Now, worldwide, what are they doing with sickle cell trait screening or sickle cell disease screening? Well, here's a list of many of the countries in the worldwide that are most affected by sickle cell trait. And really, this is in its nascency. There's only very few places that do have sickle cell disease screening. And most of these programs are not national programs, but really just local programs that are being developed. So this is up and coming. But in most other countries, they do not have national programs like we do here in the States. So as I mentioned before, one of the major barriers for using newborn screening for sickle cell trait is that, yes, we can screen and we can find individuals with sickle cell trait, but that information does not always get to the person who has sickle cell trait or to the parents of that child. So as you can see right here is just a graph of what happens when you screen positive for sickle cell disease. So if a child screens positive for sickle cell disease in the States, the majority of the states, so 100% of states, will tell the primary care doctor. They'll also tell a hematologist so that this baby gets directly put into a hematologist's office. For sickle cell trait, though, you can see right here that primary care is less likely told. Hematologists are really never told. And then the person who really is told, and only about in 37% of states, is the parent. And the way in which this happens can be extremely variable, all the way from some states actually providing genetic counseling to parents who have children with sickle cell trait, to things like in my state, in Maryland, is just sending a letter for sickle cell trait and notification. And that letter, as you know, when you're a very busy parent, that may go straight into the garbage, or you may notice it but not think much of it right at that time. So whether that information ultimately gets to the child is really unknown. So this is here just to emphasize that point. If you do screening for sickle cell trait, it certainly doesn't mean that individual was notified about their sickle cell trait status, at least right now in the United States. So there was a study that was performed now quite a long time ago in 2008 that surveyed individuals about, do they know about their sickle cell trait status? And 84% of people said they didn't even know their own sickle cell trait status. And part of that is because there's really no standardization of how pediatricians relay that sickle cell trait status to parents. There's no standardization about how states do that. And it's unclear, again, if I were to send a letter to a parent, does that ever get relayed to the child? Sickle cell trait also is not often recorded in electronic medical records, so it doesn't move forward with an individual as they grow up, not in most states. Notification, so let's say we were to notify everybody about their sickle cell trait status. Well, sometimes telling somebody about sickle cell trait certainly doesn't mean that they know what that means. So there was another study that was performed just asking individuals, what do they think? What happens with sickle cell trait? Well, it turns out that there's a lot of misinformation out there. So 31% of individuals thought that sickle cell trait could actually turn into sickle cell disease, which is clearly not correct. And 17% thought you could get sickle cell disease or trait from a blood transfusion. Also not correct, because this is a genetic disorder. So we also need to make sure that not only are we notifying people, but we're educating them about what does sickle cell trait mean. So now just going back to that initial case. So if you remember, the couple was shocked that they even had a child with sickle cell disease, even though the mother knew she had trait. So what can we do at this day and age to better educate and empower our patients? So first thing we can do is increase the infrastructure and funding for notification of sickle cell trait carriers from the newborn screening program. And that includes re-notification, again, of that individual once they hit reproductive age. Some states are doing better about this. I think Indiana does have a program that does this. California has been great about doing a sort of re-notification programs, as well as genetic counseling programs. So I think it's all about funding and advocacy to get this done. We also need to develop standards on how primary care doctors relay and educate their patients who have sickle cell, positive sickle cell trait screens, and improve utilization of the electronic medical record to make sure that the sickle cell trait status follows forward with a patient through the system. So now I am going to switch gears a little bit and really talk about the clinical implications of sickle cell trait, because this really is what a lot of people are worried about. What happens if I do have sickle cell trait? What am I at risk for? So we did a study in 2018 of all of the literature out there, a systematic review to see which complications, of which there has been many that has been reported in the literature, actually have evidence that they're associated with sickle cell trait. There were very few that had a high degree of evidence, and the ones that did have a high degree of evidence were chronic kidney disease and venous thromboembolism, or blood clots. There was another complication known as exertional rhabdomyolysis, or breakdown of the muscles with exercise, that had a moderate strength of evidence. And then there were a few complications here at the bottom that there was a possible positive association with sickle cell trait, but there's really not that much evidence. And these things also tend to be really exceedingly rare. And those include sudden death, renal medullary carcinoma, and splenic infarction. Now, the ones that are bolded here are the ones that I'm going to speak specifically about, because these are the ones that individuals need to be most aware of. So we'll start off with sudden death. So there have been reports, and many of you may know, either from the military or from the NCAA, that individuals with sickle cell trait are at risk of sudden death. Now, we don't really understand the mechanism behind this. Some of this is that we think that there might be with very extreme exertion, for example, for what happens, the type of exertion that happens in the military or the NCAA, that there's local sickling that occurs in the heart that causes arrhythmias and may be associated with sudden death. The reason why this first came into even the knowledge of the public was because in 1987, there was a military study that was performed by this group called Clark et al. And what they did is they looked in the military at a review of 62 deaths, so a very small number of deaths among 2.1 million US recruits. And this was back in the 70s and 80s. They looked at what happened in these 62 deaths. What was the prevalence of having sickle cell trait in these various different groups? So they looked specifically in this small group of these unexplained deaths, of which there were only 28, where it wasn't a gunshot, wasn't a non-sudden death or a battle-related death. These were just unexplained deaths, and they looked at how many of these individuals have sickle cell trait, and they found that 12 out of the 28 had sickle cell trait. Again, we're talking about small numbers, but when we're looking at that, that's about a little less than half of the individuals had sickle cell trait, and so the risk that was calculated was higher for individuals who have sickle cell trait. But again, it was only 12 individuals with sickle cell trait who actually ended up having this complication. But because of this, this sort of became a point of awareness about sickle cell trait and its associated with sudden death. After that study, because people in the military became aware that this could be a complication, the military actually instituted some protocols known as universal precautions. And they did this because they realized that people were having exertional death, all individuals, not just those with sickle cell trait, when they were doing too much exercise. So what can they do to even decrease the number of deaths among everybody who's in the military? So they did these universal precaution protocols, which included things like increasing hydration, very simple things. Heat acclimation, if it's too hot outside, that we make sure that people are acclimated to heat or not doing exercise in very extreme temperatures. Allowing rest periods, doing early intervention if people do look like they're having heat-related or exertion-related injury. So they did all of this back in the 80s when that other study was published. And now there's a new study that was performed in 2016 to see what happens now in the more modern age with sickle cell trait and its association with sudden death. So this study was performed by Nelson et al. In 2016, and they now looked at 96 deaths that occurred in about 50,000 Black recruits in the 2000s. So this was after institution of universal precautions. And very interestingly, they found no significant difference in death among sickle cell trait and non-sickle cell trait after the introduction of universal precautions. So it seems like these very simple measures were enough to completely mitigate or eliminate that risk of sudden death associated with sickle cell trait in the military, which is great. However, they did see that there was another complication that still, despite universal precautions, does seem to be associated with sickle cell trait, and that is exertional rhabdomyolysis. Again, as I mentioned before, this is with extreme exertion. Individuals can develop local sickling in the muscles, and they can develop a complication where they have severe muscle breakdown. So again, this is pretty rare. Looking at the cases, about 42 out of 3,500 individuals with sickle cell trait, or only about 1.2% of people who have sickle cell trait in the military will ever develop this. It's a very small population, but that is higher, that percentage is higher than those who don't have sickle cell trait. In addition to sickle cell trait, there's many additional risk factors that put you at risk for getting exertional rhabdo, and that includes medications, obesity, drug use, and smoking. So these things sort of add to the risk in people, in addition to sickle cell trait, to develop this complication. So just to summarize, in terms of exertional injury and its association with sickle cell trait, how do we counsel individuals about this? Well, number one, the most common thing that both patients and parents are worried about is this risk of sudden death. So one thing is to remember, this is an exceedingly rare complication. It really only occurs in very high intensity exertion situations, such as Division I football practice, the military. It's really limited to certain situations. And that risk can be mitigated or almost eliminated by instituting these things called universal precautions. Exertional rhabdo, though also occurs, is also rare, and again only occurs in these high-intensity exertion situations such as the military or football practice. So physicians and recruits need to be aware of this complication, avoid those additional risk factors that I mentioned before in terms of drug use and alcohol use and smoking, and then seek help early if they are to develop any symptoms that are like muscle cramping or suggestive of them having this exertional rhabdo. In general, the American Society of Hematology does not advocate for screening for sickle cell trait because there are certain things we can do to prevent these complications in everybody. However, I will say that in the NCAA and some parts of the military, they are screening for sickle cell trait up front so that individuals know their status. Now I'm going to switch gears to renal injury and sickle cell trait. So for a long, long time, this is a study that was performed in 1970. We have known that sickle cell trait affects the kidney. If you look right here, these are renal injection microradiographs of the kidney. And this is a particular part of the kidney known as the renal medulla. You can see right here in a healthy individual, these vessels are like nice and straight, perfectly organized. In somebody who has sickle cell trait, this is an adult, you can already see that this is disrupted, this vasculature. And then in sickle cell anemia, it's very disrupted. So we know that it probably has something to do with that hemoglobin S that you have, that individuals with sickle cell trait have. So we knew about this from the 1970s and then performed a study to try and figure out, well, if you do have this disruption of your vessels, does that lead to an increased risk of developing chronic kidney disease if you have sickle cell trait? So we performed a very large study. This is using some existing studies that were already occurring in the United States, really to look at cardiovascular risk, and ask that question: is sickle cell trait associated with kidney disease? There are about 16,000 Black individuals who were part of this study, and they came from various different cohorts. One, which was the Jackson Heart Study, that was a Black American only study, the Women's Health Initiative, which was a women's only study, multi-ethnic study of atherosclerosis, which had multiple different ethnic groups, and then there was also a young adult cohort. So these are very varied cohorts. We were looking in all these different populations, do we see any association? And in fact, we did. So here, looking at the risk of developing chronic kidney disease, the risk was about 1.8 or about 80% higher among those who have sickle cell trait compared to those without. That's just looking at all of the individuals in these different cohorts. If you have trait compared to if you don't, are you at risk for kidney disease? And in fact, you were. And the same thing applied for protein in the urine, which is another marker of kidney disease. Individuals with sickle cell trait were about 80 or 90% at a higher risk of developing this. And this was even after adjusting for other sort of risk factors that are associated with kidney disease, such as age, diabetes, and hypertension. But the next question we wanted to ask is, okay, if individuals with sickle cell trait are at risk of developing kidney disease, does that mean that they eventually end up with end-stage renal disease and need to be on dialysis? Because obviously that would be an important factor. So we had to use another cohort for this. This was using the REGARD study. This is a very large study with a total of 30,000 individuals in the United States. And it was really initially developed to look at stroke risk. But as you can see right here in the map, really it had a Black population as well as white population here in the United States. And we looked really at the 10,000 Black Americans within this cohort. All of them were directly genotyped for sickle cell trait. And then we ultimately linked to records of end-stage renal disease to see if there was an increased risk. And in fact, we did find that there was an increased risk of developing end-stage renal disease and being on dialysis if you had trait compared to if you did not. And that this risk was really as high as another genetic factor known as ApoL1, which before this was the most common genetic risk factor that had been in the literature associated with end-stage renal disease. But one thing I want to emphasize is that not all sickle cell trait is the same. So this is a study looking at kidney disease and kidney manifestations in individuals who have sickle cell trait, but also have another genetic risk factor, or a genetic factor known as a-thalassemia. A-thalassemia is also in about 30% of African Americans, And you can have sickle cell trait and also have alpha-thalassemia. That combination is very common. The reason why alpha-thalassemia also exists is because it also confers resistance against malaria. So when you get both of this co-inherited together, actually it protects against kidney disease. So when you get them both together, it decreases the amount of percent S that you have, or sickle hemoglobin that you have, and you're at a decreased risk of developing complications with kidney disease. And this is just showing here the association between this one particular type of kidney disease known as hypoxemia, or urinary concentrating ability, and its association with how much S you have. So we looked at this even in chronic kidney disease. If you have alpha-thalassemia and you have sickle cell trait, does it help protect you? And in fact, we found out that it does protect you. If you have both of these things together, you are not at increased risk of developing kidney disease. There's a lot of work to do in this area just to see, well, we can't call everybody with sickle cell trait the same risk. We have to be looking at additional genetic risk factors in individuals to really predict their risk. So just to summarize, kidney disease and sickle cell trait. So renal complications in sickle cell trait is common. Renal complications in anybody is, any Black American is pretty common. So if we were to talk about this, it's about 20 to 30% of middle-aged Black Americans with sickle cell trait will have kidney disease, and that's in contrast to about 10 to 15% of Black Americans who do not have sickle cell trait. Not all sickle cell trait carriers are really at risk for developing chronic kidney disease. As I mentioned, if you have alpha-thalassemia in addition, it looks to be protective. So right now, we don't have enough information about sickle trait and kidney disease, so we are not yet screening individuals with sickle cell, with chronic kidney disease for sickle cell trait. And in part because there's really nothing we know to do about it. So there haven't been any studies about using particular types of treatments in individuals who have sickle cell trait that's any different than anybody else. So there are some potential ongoing studies that will try to address this question. Now I'm just going to switch gears to another kidney complication, which is extremely rare, but is associated with sickle cell trait. And so individuals do need to know about this. There's a type of cancer known as renal medullary carcinoma. Only a very minute fraction of individuals with sickle cell trait will develop this. Very minute. In fact, we can't even quantify how many because it's only in case reports. However, it does seem to occur almost exclusively in individuals who have hemoglobin disorders. The median age of somebody who gets renal medullary carcinoma is about 22 years old. And 50% of those cases occur in children and adolescents, 50% occur in adults. It almost always starts with blood in the urine. So right now, what we do recommend is anybody who has blood in the urine and has known sickle cell trait should get, oftentimes what they'll do is send for a renal ultrasound to look to see if you have this. Now if you have sickle cell trait and you have blood in the urine, there are many different reasons why you can have blood in the urine, and sickle cell trait itself can lead to blood in the urine. That is completely benign. But because of this, physicians and patients should just be aware that they should get themselves checked out if there is blood in the urine. We still need to do a lot more studies to figure out how do we predict who that minute population of sickle cell trait individuals who are going to get this, what additional risk factors do they have? And we assume that there are genetic risk factors. All right, now the last complication that I'm going to talk about is venous thromboembolism. Venous thromboembolism is another word for blood clots. Blood clots tend to occur in the legs and then migrate up to the lungs. Now, this is a very rare complication that occurs, although not as rare as renal medullary carcinoma, but still not very common. We did this study here using the ERIC study to look at all the blood clots that occurred in there at over 22 years. And we compared those people who had sickle cell trait compared to those without. Here in this first panel, you can see right here is the dashed line. Those are individuals with sickle cell trait. This solid line are those who do not have sickle cell trait. And you can clearly see that the risk of getting a clot seems to be higher if you have sickle cell trait. Panel B here is looking now specifically at blood clots in the lungs. And again, you can see that sickle cell trait seems to be associated with this. But when we look here at the risk of developing a clot only in the legs or very isolated to the legs, there does not appear to be a difference. And that really relates when we look at the hazard ratios or the risk of developing it. So the risk of developing a blood clot in the legs if you have sickle cell trait compared to if you don't is about 2-fold higher. Now, why does this happen? Why is there this discordance between getting a clot in the legs or in the lungs? We don't really know. We don't really understand why that happens, but part of the reason we think it could happen is because blood clots tend to occur in the legs in a particular area of the legs, near valves in the legs, and those may be more likely to embolize or go up into the lungs. But we're not really sure why are we seeing this discordance between the two types of clots in people with sickle trait. So just to summarize, how do we counsel individuals about their risk of developing blood clots? Well, the risk of developing a blood clot if you have sickle cell trait is modest at best. It really isn't that high. So if you develop, so the risk of developing a clot, the incidence is about 4.8 per 1,000 person years. Only 4.8 out of 1,000 individuals will ever get this. And it's a very similar risk to what we call low risk thrombophilias in the white population. You may have heard of things like factor V Leiden or a prothrombin gene mutation. It's about as low risk as that. But we do see this strange relationship in sickle cell trait that we don't see in those other thrombophilias, where the risk of getting a clot in the lungs seems to be higher than getting the clot in the legs. And again, we're not sure exactly why that happens. Now, again, because there's really nothing different we can do about if you have sickle cell trait and you have a clot, we generally don't recommend even screening for sickle cell trait if you do develop a clot. And it really doesn't influence, again, how long you're on blood thinners or what blood thinner we use. So again, right now, this is just in the research phases about how can we predict those with sickle cell trait are going to develop a clot in the future. So now that I have gone through all of this information about reproductive and clinical complication counseling, how can we move forward now that we're in the age of genomic medicine? Well, screening for sickle cell trait now, as I mentioned, is starting to occur worldwide as sickle cell disease screening programs are instituted. And research in sickle cell trait complications really is increasing at a faster pace. So what we need to do is to take the sickle cell trait screening that we're doing as part of newborn screening programs and notify and educate and empower our patients with that knowledge of sickle cell trait to help them with their reproductive counseling programs. And we need to continue research in sickle cell trait complications to help clarify the risks of the complications, establish the benefit of sickle cell trait screening programs, for example, for very select medical conditions, and to determine the best treatment for sickle cell trait related complications. And with that, I'll stop and I can take any questions. Thank you.
Thank you very much, Dr. Naik. That was wonderful. It was very, very informative. Have you stopped sharing your screen now?
Okay, yes.
Okay. There we go. So we really enjoyed that, and monitoring to see if we have any questions from the audience, but right now I don't see any. But I have a question, and my question is relative to screening for complications with trait. You made a statement earlier, not too long ago, about that, and you said that, well, it's not really happening, trying to see whether or not people are susceptible or liable, not liable, but I guess susceptible to get kidney disease. And you were saying that we're not really screening for that right now. You want to elaborate on that a little bit in terms of your position on that?
Yeah.
I, for one, would like to see that kind of screening done, even though it is a small, very small percentage of people that can, that can get this or have that. But what's your position on that?
Yeah, I think that's a great question. So I think the reason why we're not recommending it up front is because we can't do anything different about it if an individual has sickle cell trait. But I think you make a great point that people want to be empowered and know that they have the risk. up front. And I think that that is changing. So I will say in the 1970s, when Nixon first instituted some screening programs, there was a lot of discrimination if individuals had sickle cell trait, or they felt that they were getting a lot of discrimination. That tide has turned. I think now individuals really want to know about what they have and know about their risks. So I agree with you. I think that we are moving into a different era where people want to know their information.
Okay, great. Thank you. Also, Dr. Tamia Austin has a question that I see, and she says, based on the late stage diagnosis of RMC, would you recommend annual kidney ultrasounds for sickle cell trait patients?
Yeah, so in general, because it is so exceedingly rare, we do not recommend screening even up front. And again, as I mentioned, at least invariably it is associated with hematuria. I think that might be an early sign at this moment. That's about as much as we know. They are doing bigger studies in Africa where the prevalence of trait is higher to see if they can really come up with what should those screening guidelines look like.
Okay. And we do know that because we have a client here in our area whose son passed away from RMC at the age of 17.
I'm sorry.
And he was diagnosed and he passed away 7 months later. And so her position on that was nobody ever told her that this could be a problem. And
Right.
she wasn't ready for it. She wasn't ready to look out for it. And so I think that's one of the reasons why I have the position I do, which is we've got to find a way to screen for it.
Agreed.
And then Gladys, you see there's another question here. Gladys Soriano says, do you have any data on those who have sickle cell trait get infected with COVID related to clotting risk?
Yes, so that's a great question. That is certainly a question that's been posed to me many times. There are no current studies that have looked particularly at this risk factor. There's been a lot of speculation about whether there will be an association, but no definitive data. I will say that there are some studies that potentially might be forthcoming in that area.
Okay. Yeah. Is there anything else, in your opinion, that should be happening that isn't happening, that we haven't touched on?
I mean, I do think a lot of it is about taking the information that we have and really linking it to the patients. That is our major barrier at this point. And a lot of that, I think, is just because there hasn't been emphasis in doing so. And so I think, now that this is coming to the forefront, as I mentioned, the tides are changing in terms of the way patients really want to know about their own genetic risk factors. This will start to change. I see two other questions, maybe from Emily.
Yes, Emily Meyer.
So one of them is, are any states that include sickle cell trait status in their immunization registration? So not that I know about states like actually following sickle cell trait status. I don't know, Emily, if you know of any places. And then there's another thing that says, I'm wondering if that might be a way for primary care doctors to remind adolescents of their sickle cell trait status. And I think that's a great idea. So part of what she's mentioning is using the electronic medical record to try and actually put the onus a little bit on medical professionals to make sure that they're screening or that all individuals know about their sickle cell trait status at reproductive age. And I think that would be a fantastic idea on how we can do it, and maybe it would require less funding at the state level because we can start instituting it at the medical level. I think it's a great idea.
Along that line, I've been doing some research myself on immigration and sickle cell trait, and we're not doing a really good job of tracking that. People are coming in and they're not getting screened when they come in.
Absolutely. Yeah, you're right. There's like many populations where this is just not even happening. Screening isn't even happening.
Yeah. Okay, well, I think that's it. I don't see any additional questions, but I certainly thank you so much for you being here with us today. You've done a great job and we really appreciate you. And I look forward to the opportunity to meet you in person one day. I certainly hope we can do that.
Awesome. Well, thank you for inviting me.
All right, and thank you so much. Let's see that we have Dr. Austin on now. Excuse me, Dr. Owens, I'm sorry. I was looking at the wrong page. Hi. Okay, we're going to do a couple things real quick, and then we're going to get back to you, Dr. Owens.
She's catching it. Yeah. They don't see me when they see you.
Yeah, they do. We need to, you can match you. Down here. Stop video.
You hear a lot about this, but let me tell you, COVID-19 is real. Rise above the myth, elevate your mind, and choose life, not death. Life is the way to go. Think twice and act
No,
once.
I'm still seeing Dr. Naik.
This is real. Remember to social distance yourself 6 feet. Stay at home. Wash your hands frequently. Cover your
She might have did that.
Clean and
on her
disinfect
end.
touch surfaces. Wear a mask in
Like I just
public.
did.
Oh,
This
okay.
is real.
Welcome, Dr. Owens. How are you this morning?
I'm doing great.
Great. Well, it's really good to have you here. I'm going to give a little bit of your bio information, and if I say anything wrong, please correct that. And if I do it, it's not intentional. That's for sure.
No worries.
So anyway, it's our pleasure to have Dr. Michelle Owens. Dr. Owens is a native of Birmingham, Alabama, and a resident of Jackson, Mississippi. She received her medical degree from the Medical College of Virginia and completed her residency training in obstetrics and gynecology at Johns Hopkins Hospital in Baltimore, Maryland. She completed her subspecialty training in maternal fetal medicine at the University of Mississippi Medical Center, where she now serves as professor in the Department of Obstetrics and Gynecology. Dr. Owens is one of the few individuals who has studied and written about sickle cell trait and pregnancy, and that's why we invited her to be a part of our panel today. We're delighted to have Dr. Owens with us, and we are very happy and interested in hearing what she has to say on this very, very important topic. And it's now my honor to introduce Dr. Michelle Owens. Dr. Owens, thank you again. And we're looking forward to what you have to say on a topic that is really important, but not talked about very much.
Absolutely. Thank you so much for having me. This is truly an honor for me to be considered and to be able to address your audience today. I agree that this is a very important topic and has kind of become a labor of love for me as I have had the unique opportunity to practice in an area where we have a very high African American population. And I realized the luxury and the privilege of my unique practice situation in being able to help raise awareness even among other providers, and to help make people a little bit more comfortable in caring for these women, not only those women who actually have sickle cell disease, but in helping to prepare those women who have been identified as having sickle cell trait. And I think, as many of the speakers who've been on earlier today have already kind of shined a light on, is the issue of this not really being as benign as many people have thought, and kind of increasing the importance of increasing awareness for those things for which women and men who have sickle cell trait are at increased risk, but also kind of what that means with respect to, I guess, marrying technology and what we have available now to help people to plan and to be more proactive about some of the more significant potential issues that could arise in their healthcare. And I think I want to commend you for bringing this out to the forefront so that people will have an opportunity to kind of learn more and be more aggressive and more participatory partners with those of us who are healthcare providers in ultimately the determination of their overall health and wellness.
Great. Well, thank you. And we're really looking forward to what you have to say. And we did try to pull together different aspects of the impact of sickle cell trait. And that's why, you know, we had Dr. Naik, and we're talking about the reproductive, not the urinary system. And now we're talking about the reproductive system. And we know that these are important things that people just don't hear about. And we want to try to add as much information as we can. So we're going to give you the stage now. And if you would go ahead and share your screen and get ready to do your presentation, we'll let you have it.
All right. So, let's see if I can. Hopefully this will work.
Let's give it a try.
For all of my Zoom experiences.
Down at the bottom of your screen, you should see a share the screen.
Yeah, I've got that part.
Okay.
It's just I'm getting a prompt from my computer about the about allowing the sharing to occur. Okay, here we go.
There we go.
You see it?
Yep, we see it.
All right, so we got
Great.
this thing going. Now we'll go ahead and get started. So for the purposes of this talk, I am going to take a little moment to discuss some things related to sickle cell disease as well, just because I think it's really important.
Never mind, caught up. I'm sorry. I'm sorry.
No worries. Can you hear me? Okay.
Yeah, we can hear you now.
Okay, perfect. So for the purposes of this talk, I'm going to also touch on sickle cell disease in pregnancy, because there are some unique challenges that we as maternal fetal medicine specialists and obstetricians have to address or deal with as it pertains to sickle cell disease. And again, as I said, I practice in the Deep South, if you can't tell that from my accent. We have a large African-American population in the area where I practice. And so this has become one of the things that has become a very routine part of my practice. And it has been my pleasure to be able to learn from my patients and also to share what we have learned through our consistent care of people with sickle cell disease and trait to kind of help increase awareness and to also facilitate best practices in the care of these women. So we're going to address kind of the things that people need to know. And there may be some things here that you've already heard and some of those things which may be new to you. First of all, I have no financial disclosures. That being said, as you can see, I am the mother of 3 small children. So if anybody would like to do that, throw that information in the chat. I'd be willing to entertain any offers at the end of this talk. So what we'll do is first talk a little bit about some complications of sickle cell disease in pregnancy. I just kind of came up with these objectives as things that might be important takeaways. Some of the complications of sickle cell trait, again, which you may have already heard. And then we'll talk about the prenatal screening and also diagnostic options that are available for mothers with sickle cell trait. So, of course, as we all know, September is Sickle Cell Awareness Month and has been since 1975. I won't say where I was in 1975, but I will say that it doesn't seem like it was that long ago. But I'm so glad that there's an opportunity to really turn the attention of the healthcare community to this very important disease process. Of course, it is a hemoglobinopathy. We have single gene disorders which provide us with hemoglobin variants and also includes the thalassemias, but of course today we're going to be focusing on sickle cell and sickle cell trait. I didn't want to get too overly scientific, but I do think that this is a very interesting opportunity for people to know how elegantly our bodies are designed and how they work. And so I threw in this picture, which is just anybody who's taken a biochemistry class is probably rolling their eyes right now, but it just shows you the actual hemoglobin molecule, which you know is what transports oxygen on our red blood cells through our blood vessels. And so the hemoglobin molecule normally is made of 4 different chains. 2 of them are alpha chains plus 2 other chains. And depending on what those other chains are, it will tell you what type of hemoglobin. So when we talk about the normal types of hemoglobin that we have in humans, they actually vary with development. So there's a different type of hemoglobin that we find in the fetus. which is different from the adult hemoglobin that we see once we are born and grow up. And so there are different types of hemoglobins that exist at different developmental stages, and we can actually see the progression of from one particular type of hemoglobin to another. For example, the transition from fetal hemoglobin to adult hemoglobin that occurs even after the baby is born and through the first few months of life. So the typically normal types of human hemoglobin that we see are hemoglobin A, hemoglobin A2, and hemoglobin F. I am a fan of hemoglobin F because hemoglobin F, which is fetal hemoglobin, also tends to confer some degree of protective effects in those individuals who have sickle cell disease or those people who have other kinds of thalassemia. So for example, with people who have a combination of sickle hemoglobin and beta thalassemia, you can see elevations in hemoglobin F, in the hemoglobin F percentages, which can also confer some degree of protection against hemolytic crises and those things. And it's just about the way that these different types of hemoglobin interact with oxygen and the way that they carry oxygen throughout our bodies. So when we speak about sickle cell disorders, of course, it's an autosomal recessive hemoglobinopathy. So that means that you need two different abnormal genes in order to manifest the disease. Of course, you know that it's a single substitution in the beta globin gene. So we talked about two different types, two alpha chains, adult hemoglobin, typically two beta chains. If it's the beta globin gene where you have the substitution, valine for glutamic acid, then of course it causes those cells to sickle. This is common in people, of course, of African origin, but we also see it as well in Mediterranean populations, which is something that a lot of people can forget. And so when you think about the history of especially the colonization of North and South America, then you can also understand why we can see higher frequencies of abnormal hemoglobins in different populations. So it's not just limited to, of course, the continent of Africa, but people of African descent and also Mediterraneans as they too spread out across the globe and began colonizing other portions of the world. So just a few little quick facts about sickle cell disorders. Of course, is the most common inherited hemoglobinopathy in the United States, and about 1 in 300, so depending on where you're reading, between 1 in 3 and 1 in 500 African American newborns that are affected, about 1 in 600 with sickle cell anemia, and about 1 in 12, or roughly 8%, are carriers for sickle cell trait, which is the thing that has the largest implication, I think, in the African American population. And there's been some discussion already about some of the challenges with, first of all, prioritizing this to a point where we felt like it was something that needed to be screened for routinely, and then secondly, translating that information once we know of it so that people recognize that it's something of importance and continue to carry that information with them throughout the course of their lives as a significant part of their medical history. And I always like to use this picture. So you may recognize this young woman. She's a young woman now. Her name is Giovanna Poli, and through the evolution of sickle cell awareness, you know, at one point in time, the children who were the ambassadors were called the poster children. And so she was selected to serve in this role in 2012. And I like to show this picture of Giovanni. If you have an opportunity, you can go online and actually see her video that she did to explain why she should be chosen to be the sickle cell ambassador. And it's really because when many people think about sickle cell disease or sickle cell trait, they don't think of a little girl who looks like Giovanna. And I thought that that was so compelling because she helps us to remember, especially now that the world has become so small, that it's not what you typically think, and that this is still an important health issue that can affect people in many ways. And it may not be what our own personal biases may allow us to believe are the people who are at risk, that this is now really a global situation, a global disorder, and we really need to think about the possibility of these genes being hidden in a variety of people who may not necessarily have the outward appearance that we would typically ascribe to sickle cell. So of course, this is a map that just shows the geographic distribution of hemoglobin S in the world. And this hasn't really changed very much over the past 10 to 20 years. But again, as people are continuing to move more and more and the world becomes smaller and smaller, I'm sure that we will see this continue to grow and evolve, where this will be one of those things that we'll see representation pretty much in every space as it pertains to the distribution of hemoglobin S. Fortunately, the back part of that is that we will have opportunities to be able to address and identify those individuals, but we first must have a level of suspicion to interrogate that. The protective effects of sickle cell trait against malaria is very well known and has been one of the main reasons that we have ascribed the ability for this to be so widely permeated throughout the African continent. It's because that has conferred some degree of protection against death from malaria. So if we talk a little bit about the genetics, and I didn't want to go too deep into the weeds on this, but this is just a really quick synopsis that I think shows very well pictorially the issue of the genetic distribution and how this is inherited. And so I kind of draw something similar to this when I'm working with patients to help them understand what, if you have two parents that have sickle cell trait, how you can determine what the likelihood is for them to have affected children. And so it is Mendelian inheritance, and it's autosomal recessive. So again, you have to have two abnormal genes in order to manifest the disease. If only one of those genes is abnormal or the sickle type, then those people are considered, of course, those who are carriers or with sickle cell trait. If you have a person with a history of sickle cell trait and one who is normal, then 100% of their children will have sickle cell trait or be carriers. Why? Because one parent contributes one normal gene, one contributes a sickle gene, and that is throughout the distribution of all of their children. If you have a person who has sickle cell disease, who then has a partner with sickle cell trait, then you'll have 50% of those individuals be affected and 50% will have sickle cell trait. And of course, that doesn't mean if they have 4 children, it'll be split right down the middle, but this is just how the genetics work out, the probabilities across the board. Now, of course, when the two gametes get together, how they actually come together and what genetics goes in which direction, we can't really anticipate, but these are what the numbers show us based on the type of inheritance that they have. It can get more complicated, of course, as you start to add different types of hemoglobin variants into the mix. And so that's why it's really important, number one, to know your status. And then number two, to consider that when you are deciding to plan your families. And that's one of the things that I talk to my patients about. And it's been very informative to me in having conversations with women when I ask them about the status of their fathers, the baby's fathers. It's really interesting to me how little people know about their status, whether or not they're carriers. We typically have screened for this in pregnancy for a long period of time. So most women will know if they have any hemoglobin variant, if they have C trait, if they have sickle trait, or if they have beta-thalassemia trait or any of those things. They typically will know that information because we screen for it in pregnancy. If it's their first pregnancy, many women don't. But again, you've heard this is part of the newborn screen. And so reproductive age women have had the opportunity to have that information known or at least interrogated at some point in time in their lives. But a lot of them just don't carry that information with them or haven't been well informed. So even though within the African American community, we probably all, I think if you ask any African American person, they all know someone who's had sickle cell or sickle cell trait. It's really remarkable to me how few of us really know our own individual status and how little we really know about the genetics. When I ask, well, does the father of the baby, is he a carrier for sickle cell trait? And they'll say, well, no, that doesn't run in his family. And it doesn't necessarily, as an autosomal recessive trait, have to be something that all of your family has. And that person could actually be a few generations back, and that gene could still kind of be passed on without you having someone who's manifested the disease. So I think it's really important. Can express how important and how excited I am about the work that's being done to try to help people carry this information throughout the course of their lives. Number one, to continue to ask the question for all of the babies that are born, but then secondly, to make sure that that information gets propagated and gets shared in the appropriate ways so that we are informed about our status, so that those kinds of questions and those kinds of that kind of information can be transferred to the healthcare providers to be able to provide people with optimal care. So this basically is just a way too busy slide that shows the true pathology about how we have the normal adult hemoglobin and how it forms together, comes together on the surface of the red cell, and how you get that nice little biconcave disc. And then you can see with sickle cell hemoglobin, the genetic change in the primary structure, which is actually just a single point mutation, one single change that totally changes the configuration of that hemoglobin molecule, and then in turn contributes to the abnormal formation of the red cell when it is deprived of oxygen. I'm a visual learner, so I like to throw in lots of pictures to kind of help to demonstrate some of the concepts. And for those people who like motion and GIFs, I threw this one in to just kind of show the difference between the release of oxygen from a normal hemoglobin cell, that biconcave disc that still maintains its normal shape, is able to very easily transition and pass through blood vessels. And when a cell with sickle hemoglobin is deprived of oxygen, how it can maintain that sickle, it gets that sickle shape. And then as it passes through our blood vessels, they can clump and stick together and occlude the vessels to diminish blood flow and further decrease oxygen to target tissues. So with respect to evaluation and diagnosis, a complete blood count and peripheral smear can give you some clues. Typically, those people with sickle cell have what we call a microcytic anemia with a low MCV. Of course, hemoglobin electrophoresis is diagnostic. Now, there are some instances where there have been conveyed a little protective effect if there's alpha-thalassemia or some other trait that's been associated with an abnormal or a different hemoglobin variant. The reason that I put in bold that hemoglobin electrophoresis is diagnostic is that is true for hemoglobinopathies such as sickle cell, as well as for beta thalassemia. However, if alpha thalassemia is a concern, then that is not available or not be able to be diagnosed through a hemoglobin electrophoresis. So it's really important to know that you need to order a molecular test to test for alpha thalassemia, and a hemoglobin electrophoresis is not going to give you that answer in that particular instance. And this is just a quick picture to show you in the lab what these plates look like when we are running hemoglobin electrophoresis. You can kind of see the difference in the migration of the hemoglobin variants based on positive or negative charges. And we read these and determine how far they migrate to know what types of hemoglobin are present. I always think it's nice to kind of correlate like what's happening in the labs. We know that people run the labs, but for the people who are out there who are involved in the lab portion, very important part of what's done. And I think that it's nice to kind of allow people to see kind of the bulk of what you do as well and what it looks like from your end. And I'm going to go ahead and skip that because we've kind of talked about those things. Now we'll move on to kind of the complications that we can see in sickle cell in general. Many of these, I think, have kind of been touched upon or are discussed. Of course, from a hematologic standpoint, you can have anemia, we can have increase in platelet counts and increased white counts, and of course, abnormal cell morphology. These patients are at an increased risk for infection and sepsis, and splenic sequestration can occur, which is also considered can be a medical emergency. We know that especially the young people are at increased risk for cerebrovascular accidents or strokes. They are at increased risk for clot formation, whether that be clots that just form in their blood vessels, so DVTs, or if it's through pulmonary emboli or PEs that go to the lungs. Problems with the liver, they can have aplastic crises, dactylitis, which is the inflammation, the inflammatory process in the hands and in the extremities that I think is really one of the more common things that we find in young children who present with sickle cell. And also it can lead to osteonecrosis or the death of the bone as a result of these repeated episodes of crises where you have decreased oxygenation to the bone. The kidneys, of course, can have damage. We see pulmonary infarctions in the lungs. Acute chest is something that's very common in these patients, especially in those who are hospitalized. Those rates go up. Pain crises, problems with venous stasis disease and leg ulcerations, and also complications of cardiac dysfunction after long periods of time. So as you can tell, a significant host of a wide variety of systemic complications as a result of decreased perfusion throughout the body as a result of the issues that can occur when we have decreased oxygenation and these abnormal shaped cells. When we talk specifically about sickle cell disease and pregnancy, there are certain things that we know these women are at increased risk of. So pain crises definitely can happen in pregnancy. And I typically tell my patients, we can see an increase in sickling and pain crises. We can see a decrease in sickling in sickle crises because we'll have volume expansion and some other things as a result of pregnancy that can confer a little bit more of a protective effect. It is very highly variable, and typically my patients, the best predictor is going to be how they've been controlled outside of pregnancy. And the other thing is how much or how closely they're being followed by their hematologist and their MFM to kind of make sure that we keep them in a really good homeostatic place. So if we are making sure that we are anticipating things like the physiologic anemia, which may further stress the body of a pregnant woman and those kinds of things. So those are options that are available. And again, it's very difficult to predict who's going to be the person who has a very high number of crises versus those who are lower. But typically, your control before tends to kind of predict how well you're going to do. Hypertensive disorders of pregnancy, which is another area that I focus a lot of my work and research on, is also increased in this group, as well as infectious and pulmonary complications. Women with sickle cell disease and pregnancy are also at an increased risk for preterm birth. And we also know that the maternal mortality rates tend to be higher in this patient population as well. We've also seen increased risk of stillbirth and spontaneous abortion in these women and growth restrictions. So we follow them serially throughout their pregnancy, assessing for fetal growth. And this is important, again, because of the concept of planning pregnancies and trying to let women who have complications before pregnancy to kind of know what to expect when they become pregnant and what's the significance or the influence of those at that time. And so these are all things that our patients get counseled on. And in the event that we have the opportunity to do preconceptual counseling, we like to let women know about these risks and talk about some of the things that we would do to help mitigate those. So there are many things, of course, that can precipitate sickle cell crisis, and in pregnancy, those are no different. We spend our time trying to fight against them being dehydrated. We, of course, don't encourage them to go to do things that put them in extenuating or strenuous situations like high elevations. We ask them to be careful about overexertion. In some instances, excitation and stress can precipitate sickle cell crisis, and of course, always worried about infection. We treat sickle cell crisis in pregnancy the same. And that's one of the things that I feel like I have to always pound my fist on the desk about is we treat it the same. The hydration, supplemental oxygen, evaluation for infection, and pain management. And recognizing that sickle cell in and of itself is a chronic pain syndrome, it is not appropriate to not treat or address the pain that women have for fear of some problem with the baby. We have seen a big shift in this country with concerns about the opiate crisis and those kinds of things. And it's very important, I think, for women to know and to be armed with this information that when you have a chronic pain condition, you need your pain medicines and you need to be treated appropriately. And I understand that there's a lot of fear that people have. But at the same time, we wouldn't withhold antihypertensives from a hypertensive. We wouldn't withhold insulin from a diabetic. And we shouldn't withhold pain medications from those people who actually have a physiologic reason for being in pain and they need to be treated. And that is not something that should be changed because women are pregnant. And I think that that is one of the things that we really have to do to advocate, not only for ourselves as patients, but even as healthcare providers. One of the great blessings of my job is being able to give people permission to give pregnant women the care that they so desperately need and deserve. So that is not, pregnancy is not a contraindication to pain management, pain treatment, et cetera. I think we do need to be smart about it, but at the same time, it shouldn't be withheld. And of course, antibiotic therapy if it's necessary. Really quickly in pregnancy, transfusion therapy is utilized. We have some protocols where people undergo simple transfusions where they just come in and will routinely on a certain schedule receive simple transfusions. We don't over transfuse these people. So the goal for a person who already has sickle cell anemia or hemoglobinopathy is not to transfuse them up to a hemoglobin of 12 or 13, because in some instances that can precipitate crisis by overloading them, but rather to get them to a hematocrit of around 27 to 30, which will optimize placental blood flow and still also make sure that mom has enough to adequately perfuse and provide blood flow as well as oxygenation to her tissues. Exchange transfusion is another issue, and exchanges have kind of been reserved. I think we were more liberal with them before, but now with exposures to other antigens and those kinds of things, we've been a little bit more conservative with exchange transfusions, and those have typically been reserved for those people who don't really respond very well to conservative management of their pain crises, or for those people with acute chest. And in that particular instance, the goal would be to exchange transfuse to a point where the normal adult hemoglobin percentage is around 60 to 70. So you want to decrease the variant hemoglobin S to about somewhere around 30% or so. So with respect to obstetric management, what I get to do every day, of course, genetic counseling is important. Involving the partner when he is present and engaged and available is always wonderful. But a lot of times we have to end up drawing the blood to determine whether or not the father has a carrier status. That's not really a huge impediment or a problem for us. But I think that it's one of those things that we can do, but we don't necessarily have to if somebody comes in and they already know or can document what their status is. And it helps us to kind of skip that step and move on to the rest of our counseling. We do recommend folate supplementation for these patients as opposed to iron. So we always hear people talk, oh, pregnant women need iron. Women who have sickle cell disease and trait tend not to need additional iron. They tend to be a little bit more iron overloaded, right? Because sometimes those blood cells get torn up and so they release their iron. So they tend to have more circulating free iron. They don't need iron, they need folate. We, of course, believe in pain control, trying to avoid triggers. Many people who have dealt with sickle cell all of their lives know very well what their triggers are. I tend to see these patients a little more frequently because I want to stay connected with them. I want to know how they're doing. And that way, if they do manifest any of these complications, whether related to their hemoglobinopathy or related to their pregnancy, then I have my eyes on them and we can address them more quickly. Antenatal surveillance, that's one of those MFM words that we use, where we actually do testing to assess fetal well-being for the baby. So in addition to making sure that mom's okay, and P.S., the best way to have a healthy baby is to have a healthy mom. The next thing that we do is ultrasound testing, checking the baby's heart rate, checking the baby's activity level to have some type of objective criteria to determine whether or not the baby's doing well and if additional intervention or additional care is needed. And we only do C-sections for the obstetrical indication. So you don't have to have a cesarean delivery just because you have a hemoglobinopathy. Now, specifically about sickle cell trait in pregnancy, if you do a literature review, the information regarding pregnancy complications is all over the place. For everything that you find somebody who says, yes, this happens, you can find other things that say, no, it doesn't happen. So it can be very complicated. And I think part of it is that there's a lot that we don't really know. And the other part is that a lot of times this has just been something that has been thought to be benign. And so people haven't really given it the attention that it deserves. I think as we are learning more and that we are becoming a little bit more technologically savvy on the diagnostic side, there's probably going to be much more to come with respect to this. I did put asymptomatic bacteriuria because we know that women who have sickle cell disease, and it's been thought those who also have sickle cell trait, are at a slight increased risk for genitourinary infections. Pregnant women are at an increased risk for genitourinary infections anyway, but the sickle cell trait and sickle cell group were considered to be even above that of normal pregnancy. Even that has been challenged as of late. And again, the problem is that there aren't a lot of large studies that really look at this, but rather small studies that are not really randomized controlled trials that give us, the highest quality of data. So what has happened is we've even seen a trend where even ACOG now has not necessarily recommended that these women be screened in the same way. But I will say from a practice pattern standpoint, I and everyone, that I've polled who are my MFM colleagues, we still consider this group of people at risk. Again, because the last study that was done didn't really show that to be true, but we've had data since the 1970s that have shown that to be a concern. So there will probably still be more to come as we continue to investigate more closely people who have sickle cell trait. There are, of course, barriers that exist to full implementation of available resources when it comes to prenatal diagnosis. And when I talk about that, it specifically pertains to the availability and access that women have. So the fact that a test exists doesn't necessarily mean that women have access to it. Sometimes those barriers are financial. A lot of times that tends to be the biggest barrier, just because the more recent or the higher the more complex the technology, typically the higher the cost. And so very few people may have access or coverage for these newer, more expensive tests that may actually be able to give them a little bit more information. So really quickly, I'll go over, as it was mentioned earlier, that we've done some work in sickle cell trait. Specifically, one of the interesting things that we found roughly about 10 and a half years ago, 10, I guess it's been almost 15 years ago now, wow. But we did a retrospective case control study, just looking at about 180 pregnancies in the course of 4 years. And during that time, the things that we found that were very interesting was that these women tended to have a slightly shorter average duration of pregnancy. They did have somewhat of a lower birth weight and a higher rate of fetal death. And as a matter of fact, the fetal rate of death in these patients with sickle cell trait who were also matched to people who had normal hemoglobin was about 3-fold increase over what we found. And the interesting thing was in our population, which is definitely a very high-risk population, we saw an increase in the fetal death rate even in the non-pregnant patients. So I think that does at least show that we have a slightly higher risk group. However, we did find it very peculiar that the women who had sickle cell trait had a 3-fold increase in the rates of fetal death compared with those who had normal hemoglobin. The other thing that we did that had not been done, and to my knowledge still has not been done, is that we paired these with placental findings. So we not only said, well, what exactly are we seeing in the mom and in the baby, but what does the placenta show? And in many instances, the placenta is kind of like the ghostwriter. It tells a story that otherwise would not be told. And so we looked at the placental findings, and in our placental findings for the patients with sickle cell trait, we noticed an increased rate of ascending amniotic infection, and also what's called meconium histiocytosis, which is considered to be a marker for hypoxia and intrauterine stress. And we found this not only in the placental vessels, but also in the intervillous space and the decidual side. So this is from the maternal side as well as within the placenta itself. So that was in 2006. In 2007, between 2007 and 2008, my good friend and colleague, Dr. Alan Tita, pooled some data of about 1,800 patients retrospectively. So this is 10 times the number of patients in ours. I don't believe that they were matched. I think it was just a cohort study, and they didn't find the same things that we found in our study. But I will say that our study looked at fetal wastage and loss in the mid-trimester, which was not necessarily a criteria. They looked at overall perinatal morbidity. So again, it's difficult to pair what's out there in the literature because we're not always looking at exactly the same things. But as it stands right now, we are still letting women know that for the most part in pregnancy, sickle cell trait tends to be benign. And what I'm telling women is once you get out of that mid-trimester and your pregnancy continues, the likelihood that you'll have a severe complication is pretty low. With respect to diagnostic screening options, and this was where it gets really fascinating and exciting, there is now pre-implantation genetic testing that's available for monogenic disorders. So that can be done on the in vitro fertilization side with my reproductive endocrinology colleagues. So that information can be gleaned from an IVF perspective. Again, IVF is still very expensive and not always covered by insurance. And so that can be cost prohibitive for some women who are interested in planning their families and who might want to have access to this technology. I put an asterisk by cell-free fetal DNA because while it seems to be able to answer a lot of questions, we haven't quite worked out that it is applicable in sickle cell. However, within the past few months, there has been some very exciting information coming out of Texas. I think it's at Baylor, where they think that they have found a way to help screen using cell-free fetal DNA. So there will be much more to come on that, I'm sure. I think they're now in phase, they reported on phase 1. We're moving into phase 2 of trying to fine-tune and solidify the science for that. So that may be on the horizon and will come to us probably more quickly than we know. CVS, which is chorionic villus sampling, which is done in the first trimester, is still an option, as well as amniocentesis, which is the needle test that we do around 16 or after 16 weeks. Those can be done to look at the genetic material of the baby and determine whether or not any genetic abnormalities are present. And of course, we have our newborn screen. So what do we do differently for women who have sickle cell trait? Well, in my practice, they get urine cultures every trimester, and that's pretty much our industry standard. Again, we are starting to challenge our thoughts on that, but the challenging of the thoughts has not kind of caught up with the actual practice. So while we're thinking more about it and trying to gain more information, I think most people are still doing the urine cultures every trimester. We do counsel about risk to the fetus, of course, and then we talk about evaluation for other hemoglobinopathies. So making sure that in the presence of sickle trait, that we also look for or investigate the presence of any other hemoglobinopathies. Because while a woman may have been screened for sickle trait, they may not have been screened for beta thalassemia. They may not have had a hemoglobin electrophoresis. And the recommendations now have changed such that that is recommended, but we haven't had universal uptake on that yet. And again, of course, counseling for the long-term risks, which is of highest importance. Complications, of course, as you've heard, include sudden death, exertional injury, venous thromboembolism or blood clots, chronic kidney disease, and of course, renal medullary carcinoma. And this is a problem because I see women who are reproductive age and they tend to be young women. And we know that renal medullary carcinoma in this group will oftentimes have an onset in that young, healthy period of their lives. So it may be that the time that they're interacting with us because of pregnancy care or for a desire to become pregnant, that may be the opportunity that we have to have the conversation about this. So in summary, as I close, sickle cell disease, of course, the most common inherited hemoglobinopathy, characterized by anemia and vaso-occlusive crises, and we should provide genetic counseling. And the other part is that once the patients know, encourage them to remember and to always know their status. It's associated with increased risk of genitourinary infections, as we've thought for the past almost 40 years. Again, we're starting to rethink that. And data regarding complications are conflicting. But right now, there's no strong, compelling evidence that suggests an increase for more common pregnancy complications. Of course, counseling remains vital for this particular patient population, and they should be counseled regarding the risks. Sickle cell in pregnancy is associated with adverse maternal and fetal outcomes. That we know. Women need to know about those. They need to know about pain crises, preterm labor, preeclampsia, infections, mortality, and stillbirth, as well as growth restriction. And we need to check on these women throughout their pregnancies to make sure that A, their babies are continuing to grow appropriately, and B, that we're continuing to assess for ongoing signs of fetal well-being. Treatment is mainly supportive when we have patients in crisis. Please don't withhold pain medicines from your pregnant women for fear of harming their baby. The best way to have a healthy baby is to have a healthy mom, and you do that by treating mom. Always, always, always think of infection, and make sure that if you are screening for any other concomitant hemoglobinopathies, if you're worried about alpha thalassemia, you're not going to find that on your hemoglobin electrophoresis. And this is my crew, my little motley crew, as we have grown. I always like to include them because they are definitely my why. But make sure, test early for sickle cell. And I am hoping that at some time soon, we'll find a definitive cure.
Dr. Owens, thank you so much. That was awesome. And our crew here is actually sitting here saying, wow, that was awesome. So good job.
Well, thank you.
There's people in the room that you can't see, and everybody was watching you with bated breath and just thought that everything that you did and said was very informative. So thank you so much for that. I think we do have a question or two. In fact, let's go to the questions. We have one from an anonymous attendee who says, does a hemoglobin electrophoresis detect the beta thalassemia trait, or does a person need beta sequencing?
So hemoglobin electrophoresis can identify a beta thalassemia trait. And it's interesting, when you send that electrophoresis, it's usually interpreted for you by the pathologist. And so one of the things that you'll see is the hemoglobin F and the changes in hemoglobin hemoglobin F and hemoglobin A2. And so based on the distribution of those, because of the presence of that, those different types of hemoglobin, they can determine whether beta thalassemia trait is present. So hemoglobin electrophoresis is sufficient for beta thalassemia.
All right. We have another question from Dr. Wanda Sherney at SCDAA, Michigan. She says, if the mother requires high-dose opioids, what are the concerns for the newborn?
So if it's short-term high-dose opioids, in general, the concerns for the newborn are minimal. I think people always are concerned about whether or not they'll create some kind of almost, I don't want to use the term addiction because the addiction has a psychological component and other things, but dependence for the baby. Now we do know that in women who are exposed to chronic opioid use, that there is a risk for the babies to experience neonatal abstinence syndrome. Neonatal abstinence syndrome, however, again, that's with typically chronic long-term opioid use. That is not universally true, but the rates are higher in those individuals. What I typically tell women is if you come in, you have a pain crisis, you need opioids for pain crisis control, and then we get you back to where you're controlled either with no medications or just episodic opiate use as needed on occasion for extreme pain. Those mothers typically don't have problems and their babies don't have neonatal abstinence. Neonatal abstinence syndrome in those women who are on lower dose opiates does not tend to confer a big problem. And our neonatologists are very comfortable with treating those women, and most of them have a very short hospitalization, and within 5 to 10 days are back at home with their mothers and are fine on no additional medications. So I think that while neonatal abstinence is a concern, especially considering the opiate epidemic and with illicit drug use, it is less of an issue for those women who have a medical indication for the use of their narcotics.
All right. And Dr. Sherney also asked, what about delta beta thalassemia?
So when she says delta, I'm wondering if she's talking about, I guess I don't know what she means when she says delta beta thalassemia. If you're saying a beta thal and if you're talking about with the delta hemoglobin strands, or if she's referring to something different.
Let's see.
That I'm not sure. If you can clarify that in your text chat, I would be happy to try to respond to that.
Okay, let's move on then to one from Julie Daniels, who says, how many of these complications would also be present in other hemoglobin traits such as beta thalassemia or C trait?
Really good question. So, so beta thal trait alone tends to be much more benign than with, of course, sickle cell disease. The thing that's interesting is when I have a patient with sickle beta thal, so one sickle hemoglobin and one with beta thalassemia or trait, those patients typically do remarkably well. When I have a patient with sickle hemoglobin and a C variant, so sickle C, those patients tend to be a little sicker. And they tend to behave more like patients with sickle cell disease. Like they tend to follow a similar course as those with sickle cell disease. Now, C trait alone, beta thal trait alone, they are benign. Mild anemia at best. We expect a little of that in pregnancy, but outside of that, no real complications or risks have been associated with that.
All right. Dr. Andrew O'Brien asks, do you think all pregnant women with sickle cell trait should be managed by MFM? And I'm not sure what MFM means.
That's me. I'm a maternal fetal medicine doctor.
Oh, okay. I'm sorry. I'm sorry.
But that's fine. So thank you, Andrew, for that question. I don't think that they should be. I think that those women who have sickle cell disease should definitely have an opportunity to be evaluated at least one time by a maternal fetal medicine specialist. And that's really more just to kind of outline the plan of care and to help make sure that nothing gets missed. And the other thing is, again, this is a situation, unfortunately, where women need advocacy. And I think that we in MFM have a unique opportunity to advocate on behalf of these women by giving the providers who would care for them on the front lines the permission to do the things that they need, and to be able to do that without fear, and to do that with adequate support. Because I think that's a big part of what I do. A lot of times an OBGYN may be reluctant or hesitant to give a patient pain medicines, or they may not know, should I exchange transfuse them? Should I transfuse them? And even with our hematology colleagues who don't always take care of pregnant women, having a pregnancy specialist to be able to say, absolutely, you can do that. Yes, and this is how you do it, and this is how you do it, responsibly. I think that's a really important thing. And we are just a piece of the healthcare team, but can be an important one in that role. In sickle cell trait, particularly for all that we know right now, I would say that that's not necessary. I think that it is important, though, just to kind of keep in mind that the genitourinary issues and infections, which can still be significant contributors to obstetric issues, is something that I'd still want to keep that on my radar for the time being.
Okay, and also we have one more question from Tamara Shepard, who says, in a person who has sickle cell trait and not pregnant, is ongoing anemia an issue throughout adulthood?
So I would say that ongoing anemia tends not to be. It's mild if it's present. However, we do know that there are definite risks when it comes to extreme exertion and other extenuating circumstances. There aren't a lot of people with sickle cell trait who have climbed Mount Everest, and there's a reason. So just being mindful of things like the exertion, high altitudes, and exertion in high altitudes. Those are the things that you need to be mindful of. And you had Dr. Naik on earlier, and she's done a lot of really good work, kind of even examining things like athletes, and even with the work from, the conversations around the NCAA, which doesn't have anything to do with pregnancy, but the conversations around the exertion and how it's done and the circumstances in which it's done, and being mindful about precautions and the things that people need to do. And that's why I think this is so important. It's so important for people to know so that they can take the necessary precautions, because this doesn't have to be crippling. It doesn't have to be something that creates a problem. And if you are one of the few individuals who does happen to have a complication, as long as you're armed with that information in advance, so somebody is screening and carving out that space for you, considering your circumstances, rather than just kind of brushing you off as benign, but saying, hey, I do know that these are a few things that you're at risk for, so we're just going to take a look for you. Because and I think that that's the most important thing. The healthcare system is not a one size fits all. You're not shopping off the rack in there. The best healthcare is the healthcare that is tailored for you as an individual. And as different as we all are, it's really important for you to come armed with as much information as you can, so that you can make sure that care that you get fits you the best that it possibly can.
Okay, great. It looks like Dr. Sherney tried to send in a clarification. Says hemoglobin alpha 2 delta 2 will not be elevated in delta beta thalassemia. Is that an answer to her question, or is that, I don't know if that helps clarify the question earlier.
So hemoglobin A2 is alpha 2 delta 2. So yeah, I'm not really sure. But anyway, I'm sorry. That's why I wish that we could do this in person, so you could.
Yeah, for real.
It would make it a whole lot easier.
For real. Well, you're doing very well virtually, and we're very, very happy that we've had you with us today. It's time for us, I think, to move on. But certainly we want to thank you so much for joining us today and participating and presenting. You were great, more than what we hoped for. So that's always
well,
good.
thank
Somebody
you.
tells you that. So yes, you were more than what we hoped for. So thank you so much. And we hope that you enjoy the rest of your day. You have a wonderful weekend and stay safe and keep taking care. It's good care. I'm sure you're giving those patients there in Mississippi. I'm sure they are happy to have you, just like we were today.
Thank you so much. It is truly a privilege and a blessing to be able to work with these incredible women. It's really a gift from God.
Wonderful. Thank you so
Thank
much.
you.
Okay. I think we're going to take a 5-minute break for everyone, and then we're going to bring on Dr. Joel Jaeger, who's going to talk about sports and athletics. And so, Dr. Jaeger, I see you're there, and I'm going to ask you to hold on for a couple minutes while we give everyone a break. We've been going nonstop since about 8:30. So we'll take a 5-minute break, and we will resume at, what time is it now?
10:36.
We will resume at 10:41.
Sports medicine practice outside of Indianapolis. Sports medicine training.
The Indiana Hemophilia and Thrombosis Center, IHTC, began with a vision for a center where patients and families affected by blood disorders could receive the best treatment. With extensive experience in hematologic disorders and depth of specialization in the field, IHTC's doctors, nurses, and specialists are focused on improving quality of life for our blood disorder patients and their families. IHTC is committed to providing the highest quality comprehensive services and holistic care to patients with bleeding, clotting, and other hematologic disorders and to their families. IHTC's vision is a future where people with rare blood disorders flourish. IHTC delivers patient and family-centered comprehensive care for hemophilia, thrombosis, von Willebrand disease, sickle cell disease, and other bleeding and clotting disorders, including rare conditions. IHTC values innovation, high quality, teamwork, and compassion. In short, IHTC values you. For more information about IHTC, visit their website at ihtc.org.
For those of you that were listening earlier, we were trying to get a question answered from Dr. Wanda Witten-Sherney at the Sickle Cell Disease Association of America, Michigan chapter. And she has sent in a clarification that she just wants to be sure everyone is listening hears this. And her clarification is it might be good to state that hemoglobin electrophoresis is not always sufficient to diagnose beta thalassemia. And she believes that that's a very, very important distinction to make. So it's now my pleasure to introduce you to Dr. Joel Jaeger. Dr. Jaeger, we'd like you to join us now and share your video. There you are.
Hey, can you hear me?
Good morning.
Good morning.
How are you?
Doing really well. We had a
Great.
really nice talk we just had.
Well, thank you. And it's great to have you with us too. We're going to go into a different area. We've kind of touched on it a little bit by talking about exertional rhabdomyolysis, et cetera. But we're going to let you talk today about sickle cell trait in athletes. And we're greatly happy that you're joining us today. I'm going to read a little bit of biographical information about you and tell me if I say anything wrong. I won't be offended if you correct me. So Dr. Joel Jaeger studied medicine at the Chicago College of Osteopathic Medicine and completed his specialty training at the Notre Dame Sports Medicine Fellowship. He is board certified in sports medicine and family medicine. He has provided sports medicine coverage for athletes at local high schools in the area, such as Warren Central and New Palestine. His training has also allowed him to work with athletes at the University of Notre Dame and at the 2018 preseason Indianapolis Colts camp. Get all that right so far?
Yes, sir.
All right. And then Dr. Jaeger is passionate about sports and helping his patients get back to their regular routines, hobbies, and active lifestyles. In his free time, he enjoys archery, trail running, kayaking, and spending time with his family. We're grateful to have Dr. Jaeger on our panel today, and we're really looking forward to the information he has on sickle cell trait and athletics. It's now my pleasure to introduce Dr. Joel Jaeger.
All right. Thank you for that introduction.
Dr. Jaeger, we are ready for you to share your screen and start your presentation whenever you're ready.
Okay. I just clicked the screen share. Is that working?
It looks like it.
All righty.
Yes.
Thank you for that introduction. Really honored to speak here with you guys today. So again, I'm a sports medicine specialist. I work in a small practice outside of Indianapolis, and I kind of tailored this talk specifically for kind of the athletes, parents, family members on kind of what do you need to know when if you have an athlete who's has sickle cell trait and pursuing athletics. We'll just with all my training I did at Notre Dame, there might be a lot of Notre Dame athletic pictures in here. Heads up. I have nothing to disclose. Okay, so the objectives for this talk. First, I think it's important that we discuss kind of the prevalence of injury and death related to sickle cell trait and athletics. I kind of talk about why is this so important. Then I think we're going to do a brief review of the pathology of sickle cell disease in crisis. I think this is going to be something we kind of heard in some of the previous talks, but I'm going to touch on those. Then we're going to discuss how do we go about preventing exertional sickle cell crisis in the athletic population when they're trying to perform. And then I'm going to also go back and touch briefly on, there's a lot of debate on screening for sickle cell trait in regards to athletics. So I'll kind of talk about both sides of those arguments. Here we go. So what I'd like to start off with, this is a case presentation. This happened in 2005. This is Aaron O'Neill. At the time, he was a 19-year-old redshirt freshman who was just coming in. This is at University of Missouri. You can see in this picture here, there's kind of a warm-up for practice on this day. Aaron's in the white sleeveless shirt in the second row there, and they're kind of starting their practice off at 1:35. So this is a voluntary warm-up, or voluntary workout that he came to. So they're getting ready. You can see here's Aaron. He's really getting after it. He was kind of had a reputation of being one of those guys coaches never had to get after. He's kind of a very strong work ethic and always went the extra mile. So he's kind of getting started here. It's now 1:57. Getting further into this practice, they're doing a lot of conditioning, sprinting drills, and you can see he's really starting to struggle. And his coaches are really staying after him while he's struggling during this. Getting further into the practice, you can see now he really looks like he's starting to hurt here. We're now at 2:26. And if you look at the other players that are participating, I mean, you can tell they look like they're tired, but they don't look like they're struggling anything close to what Aaron's going through. Going a little further, we're getting close to an hour into practice. The other players are starting to kind of concerned and looking at Aaron, like, okay, he's not looking right. We're getting kind of worried about our guy here. At 2:39, Aaron collapses. This was actually the second collapse that he had during this practice. We just didn't have that recorded with any pictures that he had. Coaches decided to get Aaron up. Let's get him off to the sidelines and let's kind of shut him down for the day. They 2:43, they partnered Aaron up with one of his teammates to get him to the locker room and just go ahead and kind of calm down for the rest of the day. What we don't see after this is once they get into the locker room, Aaron collapses again and becomes unresponsive. His teammate rushes out to call for help. A maintenance guy was there. They got Aaron into the back of a truck. They take him to the athletic training room for him to receive medical care. Aaron went into cardiac arrest. Was what happened when they had got him to the hospital. Following this, he was the main diagnosis they had was initially a viral meningitis. At the time, they didn't know that he had sickle cell trait, and this ended up coming out later with his autopsy. The one thing that I think kind of sticks out about this case, and this is something we're going to kind of talk about later, Aaron was kind of known as being that guy that coaches never had to get after him. He always went the extra mile. He always worked hard. So on a day where he seems like he's struggling much more than everyone else, why wasn't this kind of recognized instead of questioning, oh, he just doesn't want to work today? Why would we think, okay, maybe there's something wrong? Maybe we should just cut him a break and slow him down. So why is this topic important for this case, kind of like Aaron? This was a study that was done by Dr. Moran. This is a 10-year study, and this was looking at NCAA athlete deaths. So in this 10 years, any NCAA athletes who did die, what did they die from? In the orange section here, you can see the sickle cell trait associated deaths. There were 11 of them. There were a total of 182 deaths in the entire study. So this makes up roughly 5 to 6% of the total deaths was from sickle cell trait. Looking at another study done by Dr. Bodden, this looked at deaths related to football specifically, and this was in high school and college athletes. And you can see in the purple section, kind of in the 10 o'clock portion of this chart, is where we have our sickle cell trait, where again, there's 11 deaths. Now, some of the thought behind it, this is a 20-year study. We just looked at a 10-year study where they also had 11 deaths. The thought is in this second decade of this study, we started getting a little better at trying to look for this problem. But again, roughly we're talking about 5% of deaths are related to sickle cell trait. But in both of these studies, we're also including things like infections, people dying of, say, cancers or getting struck by lightning. So Kim Harmon's group in Washington decided, okay, how many people are actually dying from participating in their sport? And again, they specifically looked at football in this study. and they were getting rid of deaths unrelated to participating in their sport. And when you start looking at that, sickle cell trait is now a significant key player. It is tied with cardiac deaths or cardiac related deaths being the main cause, with heat stroke being a distant third. So now that kind of frames our study. This is why this is important, because this is a very significant contributor to death while playing sports. And I don't think that's something we should worry about. Sports should be fun, right? So how many of these deaths related to sickle cell trait were preventable? I'm going to argue 100% of these were preventable. So going into this, if we want to think about how can we prevent this from happening in the future, we want to go to, okay, how does this happen in the first place? So some of these slides might be kind of echoing some things that were already talked about today. Hemoglobin is a molecule in our red blood cells that helps grab onto oxygen and help deliver that oxygen to the rest of our body. With sickle cell and sickle cell trait, we have 146 amino acids that in our DNA that code for the hemoglobin molecule, and there's a change to just one of those amino acids that causes this problem. So looking at this slide, looking at the bottom row of these pictures, you can kind of see how there's a different shape to the beta subunit in hemoglobin. And kind of looking over to the third slide, you can see how these portions of the hemoglobin molecule, they can kind of link together and form these long strands. So when oxygen is removed from the hemoglobin molecule, then the hemoglobin will start to clump up and make these strands. This is what causes the sickling shape of the red blood cell. And here we have a picture where we have kind of the classic, we call it biconcave discs of red blood cells. This would be either a person with normal type hemoglobin, such as hemoglobin A, or this could be a sickle cell trait person who does have hemoglobin S, or the sickle type for hemoglobin, but they're in a high oxygen state, so they don't have the sickling. This diagram kind of better represents that we have the sickling. So off to the right, you can see we're getting some of these strands of the hemoglobin stacking up, which is causing the sickle shape to the cell. And we have this occluding the blood vessels as the red blood cells are traveling through, causing a blockage. Okay, I think this was talked about in other traits. So how do we get sickle cell? If we look at the picture off to the left, you'll notice, say a person who has sickle cell trait is having children with someone who does not have sickle cell or sickle cell trait. They're going to pass on half of their genetics to their children. So 50% of these children are going to get sickle cell trait genetics. 50% of them will not. So that means in this partnership, there would be 50% of these kids will continue to have and pass on sickle cell trait. Looking over to the right side of the screen, this is representing if two people with sickle cell trait have children. Again, 50% of these kids will have sickle cell trait, 25% will have full-blown sickle cell disease, and 25% will have the normal type hemoglobin. These pictures I put up just to kind of better show what's going on in the red blood cell with these genetics. So if you look off to the left again, this would be our normal type hemoglobin represented by hemoglobin A, and this red blood cell is only containing hemoglobin A. Looking off to the right side of the screen, this would be our sickle cell disease individual, and they only have genetics for hemoglobin S. So all the hemoglobin would be for the hemoglobin S type. Per individual we're talking about for this talk is the individual in the middle, where the half of their hemoglobin is hemoglobin A and half of it is hemoglobin S. So what's important, something different about the athletes who have sickle cell trait in general, they have a decreased ability to derive their energy from oxygen dependent pathways. So there's a couple different routes to get energy for your muscles as they're performing. Hemoglobin S does not deliver oxygen as well as hemoglobin A. It will get rid of the oxygen more quickly. So it doesn't carry oxygen as deep into the tissues as hemoglobin A does. Therefore, these types of muscle fibers have to become more dependent on other energy pathways. That's why these people tend to have a little more of a predominance of the fast twitch muscle fibers. So thinking you're faster, more explosive, stronger type of athletes versus your more endurance type of athletes. And one other thing I wanted to kind of touch base on, a lot of people, I feel like they kind of, this is not a disease of race. This is of individual inheritance. So we do know that people of African descent do have a higher tendency to get sickle cell trait, but sickle cell trait is something that can come on with any ethnicity. Okay, so kind of with having the framework on how does this work, what does our sickle cell trait athlete tend to look like? Commonly, they look like this guy here. This is Ryan Clark. So Ryan Clark is a very successful football player, played in the NFL for the Steelers, had a very good career, and was largely asymptomatic, didn't have any problems. There was one specific game where we did get in a little trouble. He had to play a game in Denver, Colorado against the Broncos, so that was a higher altitude. So this was something Dr. Owens had kind of also mentioned with having that higher altitudes or that lower oxygen concentration in the atmosphere can kind of lead to someone getting more of that sickling pattern. He developed a left upper quadrant pain, so that's kind of pain on the left side of his abdomen, kind of at the bottom of the ribs, also some nausea, some vomiting. This was quickly recognized by his medical team. They addressed it properly, and he went on to continue to have a very successful career without any problems. He just chose to never play in Denver again. But otherwise, very successful athlete who never had to stop or slow down from his career. In this picture, this is Geno Atkins. So a complication that he had suffered was something that was discussed a little bit earlier with rhabdomyolysis. Again, every word in medicine has to be about that long. Rhabdomyolysis is breakdown of skeletal muscle tissue, whether that's from lack of oxygen leading to cell death, or whether that's direct trauma. There are a couple things that can cause this. When this happens, those muscle cells will start to break down and rupture, and things inside the muscle cell leak out. So we'll get things like myoglobin, which is a protein that makes up the muscle, and creatine kinase. Those will kind of go out into the bloodstream, and then the kidneys have to filter them. That'll end up leading to, can clog the kidneys and lead to some renal failure. Then we also have some electrolytes that will also get spilled out, potassium, sodium, phosphate. Potassium is going to be something that comes in, we're going to talk about a little bit later. But this can also lead to a lactic acidosis. If you get lactic acid in your muscles and then we start to rupture, that will release this acidosis into the bloodstream, causing more of an acidic acidosis to the blood. Okay, so those are kind of more injuries and medical conditions associated with this, but what I kind of want to focus on was fatal situation with sickle cell or exertional sickle cell crisis. A study done looking at, this was a separate study, they were kind of talking about sickle cell crisis deaths in football from 2000 to 2010. And what they found, there were 11 deaths. But if you look at it a little more closely, every one of those deaths happened in practice, never in a game. And I think that's kind of important. So if we're looking at these sickle cell deaths, it wasn't just any part of practice. This doesn't happen when they're running through plays or they're practicing reads for defense or running routes for receivers. This is when they're doing conditioning. 7 of the 11 deaths happened in the off season. So this isn't even the busy football time. This is more off season conditioning. 4 of the deaths did happen during the season, but they happened earlier in the season. 2 were in the preseason during August. So again, hotter conditions, and also when there's a little more emphasis on conditioning as part of the practices. The other 2 happened in September, again, still earlier in the year where we have warmer temperatures. This exertional sickling collapse with exercise, kind of when does this happen? This can happen at any time in the practice. So when we looked at the case with Aaron, we saw that he was getting a little more to an hour or over an hour of activity when he had his collapses. But this can happen with as little as 2 to 5 minutes. Some of the other cases, it happened within 2 minutes of the first practice that they'd had. The key here is intensity of the exercise that they're doing. So what happens when we have that very intense exercise? Again, we're starting to use up a lot of the oxygen because the muscles are needing oxygen for their energy usage. So we start to get a little bit of a hypoxemia within the blood. We're also building up lactic acid, because we're also using energy from other routes that creates this lactic acidosis. We're creating a more acidic environment, and we're getting some dehydration, which even the red blood cells themselves start to get dehydrated. So these 3 conditions within the blood start to help kind of push towards that sickling phenomenon. We've done physiologic studies kind of talking about what this can happen anytime with that 2 to 5 minutes that we've seen. For cyclists or putting people on a treadmill and just having them run at high intensity, we can get blood levels with severe hypoxemia and severe acidosis within 1 to 5 minutes. So this can happen very quickly. So those are kind of some factors we worry about are internally causing the sickle cell, but what about external factors? And again, you're going to see some familiar things that were talked about in the other talks. Heat is a very large, significant contributor to causing the sickling, where you're trying to do high output, high intensity activity in hotter conditions. Higher altitude, where there's a lower oxygen concentration in the atmosphere. Also, people with asthma are at higher risk, and that's more because their lungs aren't as equipped to take in as much oxygen or oxygenate the blood as well as, say, someone without asthma. But two of the other things I think we need to keep in mind is things such as this warrior's attitude, or this kind of, and tough-minded coaches. Again, things that tend to be kind of stereotypical of like the people who do football. So Aaron would kind of fit that warrior attitude. You saw how much he was kind of struggling. This guy was hurting, but he would not stop. So he's going to be the guy who's going to try to push through the pain, push through these symptoms, when he needs to kind of, the person like this needs to recognize, okay, this is a little abnormal. I shouldn't be going through this. At the same time, the tough-minded coach, that's the stereotypical football coach, right? But if you have a guy who you should know kind of how your players respond, and if they're not responding normally, we shouldn't just have that normal mindset that they're just taking it easy, you need to push harder. So both those sides of the coin are going to help take those environmental factors and kind of up the ante, put us in higher risk situations. This was a quote by Dr. Randy Eichler. He wrote this in Current Sports Medicine Reports, where he said, "Heat is no more of a trigger for exertional sickling than altitude, asthma, heedless valor, or reckless coaching." And I think that could be, there's no studies to support this, but most of the sickle cell deaths are related to football than other sports. And I'm wondering if that's where that comes from. So if an athlete is going through sickle cell or who has sickle cell and is starting to develop these symptoms after exertion, what does this look like? What are these symptoms? They're going to start to develop some leg pain, or they'll get the sensation, my legs just won't go. They just won't let me run. They can also get some low back pain, which can be very debilitating, very extreme low back pain. They can get cramps that they'll feel either in their legs or spreading up their body. They even may just start to feel just relative muscle weakness. You could even see them start to feel kind of wobbly while they're just standing there. Chest muscles can get tight, feel like they can't catch their breath, or they're having to do very rapid breathing. It could even be as vague as, man, I just don't feel right, or I'm starting to get kind of anxious, which is kind of out of proportion for them. One comment on the cramping situation. If anyone watched a high school football game this year from August or early September, you probably saw someone with leg cramps. What's the difference? How do we tell the difference apart from these on the field? Leg cramps, you're going to have, usually there's kind of a prodrome where they start to get a muscle twitch, where they kind of a warning to what's coming, and their muscles are going to lock up and they're kind of hobbling around on these tight legs. A lot of times it's very painful and can look very dramatic. They can often be writhing on the ground in pain. But when you get there to look at them, you're going to have these very hard, contracted muscles. The sickling pain isn't quite like that. The muscles are going to look normal. They're going to feel normal and supple. Usually these people aren't rolling around writhing or yelling in pain. They're usually lying fairly still. So it's kind of a way to kind of tell those two apart just by looking at the athlete. On this slide, if we're thinking about, say, someone doing, say, the exertional collapse, well, there's a few different things that can cause collapse on the field. Every one of these conditions tends to have a set of symptoms that they have, and I kind of wanted to highlight a couple things that would help, like the way that I would be thinking about this while I'm looking at the differential, like on this athlete, trying to assess them what is probably the problem here. So I circled a couple of these points. In the sickle cell athlete, they tend to kind of slump and kind of slowly go down to the ground, or they at least have some form of control. In a cardiac cause of collapse, there's no control. When they fall, they're going to fall suddenly, and they're going to just collapse straight to the ground. When you get to the sickling athlete, usually they're able to kind of talk and communicate to you at first. This is going to be different from someone who has, say, an asthma exacerbation where they're very wheezy or they're breathless. They're not able to talk or speak very well. So you can almost kind of rule that out just by your interaction with them. And then often if you're getting into this person to get the collapse, we're going to start getting vitals. One of those things being a core temperature that we're going to need. Comparing this to heat stroke. Heat stroke, we're usually talking about body temperatures of 105 to 106 degrees or greater. Our sickle athletes, they usually don't get quite to those higher temperatures. So that's something that could also help kind of push you more towards this. It is more of a sickling cause of collapse. So once we've kind of started to recognize what's going on, we're thinking this athlete collapsed. It's more related to exertional sickling. What are we going to do? The first thing we have to do is we have to stop this activity that they're doing, and we've got to make them rest. And a lot of times that's all we need to do. Now, again, if they collapse, we're going to start checking vitals. If they need supplemental oxygen, we could give them oxygen. Checking the core body temperatures. Again, this isn't the direct cause of the problem, like say in a heat stroke, but heat does contribute to them sickling. So if we do have elevated body temperatures, starting to cool the athlete down, either with ice bath or cold race, whichever means they have available at that time. Now, if these measures don't work and we're continuing to run into problems, then we're not going to sit on this and we go into a full court press, so to speak, where 911 needs to be called. If there's an AED available, this should be attached to his chest, because even though we may not be thinking cardiac problems, we haven't ruled that out yet. IVs would be started. Someone who would be able to provide CPR needs to be available and ready. And then basically this person has to get to the hospital quickly. And the kind of the thing that I think should be in the background of the mind, just from a time standpoint, we should be thinking about this anticipate like explosive rhabdomyolysis, where if we continue to have this decreased oxygen delivery and go into this rhabdomyolysis, that we're ready to kind of respond for that. And I think this was already kind of addressed in another talk this morning, but just briefly. So what happens with rhabdomyolysis? What is this doing to cause death with exertional sickling? When the muscle cells are getting deprived of the oxygen, one, they're going to use more lactic acid as their lactic acidosis as their energy source, but then they're also going to produce lactic acid. This also, once the muscle runs into trouble and is going to die from this, that lactic acid is going to be released, and that's going to help contribute to the acidosis, which could further increase sickling. The other thing that's going to be released from these cells is potassium and the myoglobin. Myoglobin, we talked about causing renal failure as a problem, but the potassium is what is the killer. This is what can kind of contribute to cardiac arrest in the athletes. And once this problem starts, this is very difficult for people to reverse. So that's why this needs to be, we need to try to reverse this situation and prevent this from happening. Okay. So one of the things I want to say, all the studies that we've shown, a lot of the deaths related to exertional death in sports with sickle cell has been related to football. And one thing I want to make clear is that playing football does not kill people. So if people will spend a couple hours on a weekend watching football, watching a single football game, but really that ball is only in play for about 11 minutes. On average, for a football game, the typical play lasts about 4 seconds, and then there's 40 seconds of rest in between. So for this, we're talking work-rest ratio of about 1 to 10. The problem we run into, which I was kind of hinting to with this usually happens with conditioning activities, is a lot of the programs that condition people to play football, they're kind of designed opposite of what is needed to perform in a football game, where they tend to focus more on these sustained bouts of all-out activities, running 100-yard sprints, or these very fast tempo multi-station drills. And really this isn't preparing them for what the end goal is to play a football game. So this is where we have to address the problem and change the way that we go with conditioning athletes and preparing them to play. So as far as prevention guidelines, what do we do? So if we have a player who is known to have sickle cell trait, one of the big things with practice, conditioning, getting them ready, they need to be able to set their own pace. And that pace needs to be able to adapt with how they're feeling that day. the patient with sickle cell trait, as you're starting to build them up, they should also have kind of a progressed buildup in their training, and this needs to be done slowly. We don't want to jump into full intensity on the first or second day. We need to kind of start building that intensity over time. And while we're doing it, they need longer rest periods to be able to recover, make sure we can oxygenate our tissues well, so we can avoid some of the triggers for causing the sickling. And in general, like the extreme performance tests where there's just some kind of ridiculous endurance or drill test, we just don't need to do that with those athletes. Because it's really not reflective of preparing them for what they're trying to train for. Then the biggest thing, all of the symptoms that I discussed earlier that have been discussed in other talks, if these athletes are starting to experience this, they need to stop what they're doing. We need to set them out of practice, and they need to just rest and then be evaluated by either their athletic trainer, or if there's not someone like that available, their other medical staff. But that is the first and foremost thing with the prevention, is if you develop symptoms, you've got to stop. The other thing that's going to play a key role in prevention is anticipating conditions that would lead to the sickle cell crisis, or the things that would cause sickling collapse. The things we've talked about in several of the talks. Days that are much hotter than typical, or things that we're not acclimated to. Going and playing in a higher altitude where we're not acclimated to that altitude yet. Dehydration, did this athlete hydrate well the days leading up to the event? Do they have a history of asthma, or did they recently have some other illness that could push them into having a sickle cell crisis just from having that history? So those are the kind of the thoughts behind prevention. Other ways that approaches with trying to think about prevention, do we have screening is something that people have talked about doing. The NCAA does. There have been multiple screening programs for sickle cell trait that have been done over the years, and the U.S. Army used to. Currently, the U.S. Army has a no screening policy, and they try to take on universal precautions. So kind of reflective of those preventative precautions I just kind of talked about. They'll tend to space out some of their high intensity drills, allow for more rest time. When they first started switching over to this, they had done a study on the universal precautions, and what they found was during the entire duration of the study, sickle cell related deaths went down to 0. What's interesting is after the study was done, they continued to do the precautions, but then the deaths of sickle cell trait went back up to baseline. I can't really speak what that means, but when they were implementing the precautions, it did work. Across the country, newborns are screened for a sickle cell trait in their first few days of life. Pediatricians should be going over this with their parents. I think a lot of times what happens in a lot of pediatric offices is if they end up having sickle cell trait, but not full-blown sickle cell disease, they tend to be more reassured, like, oh, it's okay. They're not going to have the same amount of complications. And I think parents are going to forget that it's a problem where their patient has that if it's kind of mostly reassured that this is harmless, which isn't the case. Also, if, say, we're 18 years later, whether it's a person thinking about becoming pregnant or someone who's going to be going into more higher intensity athletics, tracking down those records from when they were babies can be kind of hard to find. There were, with several of these sickle cell deaths that happened between that period of 2000 and 2010, there ended up being a big lawsuit with a settlement in 2008 where the NCAA actually pushed to where they recommended sickle cell testing prior to participation. In 2010, the NCAA Legislative Council mandated that all athletes of Division 1, 2, and 3 will be tested prior to participation. The only two ways they could opt out of this was either they provided a documented test that could show whether they were positive or negative, and also if they chose to, they could sign a release declining the testing. A lot of people are kind of against this approach with the mandated screening. There's a few different arguments against this. One of them being they don't feel that there's a lot of very well-controlled prospective studies on sickle cell trait and exertional collapse, and also how well are we preventing this if we are screening for it. If we have this information, are we doing a good job of implementing changes to prevent what we're trying to avoid with the deaths? Some people will argue that there's such a small amount of deaths from sickle cell trait by comparison to how prevalent sickle cell trait is. So is this really effective if it's just a small number? Another thought is this could be a slippery slope from a privacy issue. This is the only kind of mandated, say, genetic screening. And is this opening up the door to where other genetic screening could be mandated for people? With this known information, what also is going to happen with this is this going to cause, say, discrimination, where, say, an athlete doesn't get as many reps and may lose, say, a starting position, or is a scholarship money that they need to be able to attend school. Are they at risk of losing that? On the flip side of the argument, there's some positives that come out of this screening. And I think this is kind of what NCAA football how they tend to look at this. If we know a person has sickle cell trait, the athlete themselves, their coaches, and their athletic trainers can really be specifically educated on early symptoms to watch for. Because this is the biggest thing that's going to change the causes if we're able to recognize symptoms early and intervene before the sickling progresses. And we can give tailored precautions specifically to those individuals instead of your football coach trying to push everyone through or give everyone breaks. They tend to know who to keep an extra eye on. With this, the U.S. Army is one large entity that can kind of enforce their policies. The NCAA is actually a conglomerate of hundreds of different athletic departments. So as far as executing how this is done, it's just a little harder to manage. So having those ability to tailor things could be a little more flexible for them. A viewpoint that I tend to take with this is it is a small number of deaths, but again, we're talking about sports. This is supposed to be fun. This is an extra. So no one should be dying from this. And also looking at this, say, with all my other athletes, I want to know if they have asthma. I want to know if they have diabetes. So if that athlete goes down, I know how to specifically treat them more efficiently. I think knowing their sickle cell trait status falls exactly into that type of customized care. So this was something that I took from one of my mentors at Notre Dame, Matt Leisler. He said, in general, the main thing that we need to think about doing when it comes to sports with these athletes, we need to create an environment that fosters acceptance of them and understanding of their condition, and we'll be able to respond and take care of this well. And that's from the athletes themselves, parents, coaching staff, athletic trainers. This is just, we have to create this environment. But the other big thing I'd like people to take away from these talks today, most of these athletes that have sickle cell trait will never have a problem and will probably lead a totally normal life. So these are some of my studies that I quoted, and that's it. Thank you for listening. If anyone has any questions, I'd be happy to answer them.
Dr. Jaeger, thank you so much for that. That was great. And wow, we think that was very, very good, very informative. We have had some questions, and I know you can see them, but I'll read them. Derek Robertson asked, have there been studies that show the percentage of athletes with sickle cell trait who experience the symptoms you have discussed?
Okay, I think is that say how many people just develop symptoms while they're in sports? I have not seen any data behind that, and I think that would be kind of hard to accurately collect. I haven't seen that just with my experience in, say, training rooms, because a lot of the people that would be addressing these symptoms right away would be coaches and athletic trainers. And as far as the documentation, I just think with all the different, it would have to be probably very small studies that would be institution specific, but I have not seen any data that's like that.
Okay, and then another question is, have you heard of any cases in high schools?
Yes. So with the studies we talked about where they looked at, it was a 20-year study where we had high school and college athletes that were studied. 9 of the 11 deaths that they had were in college athletes. 2 of them were in high school. So it seems that it's your risk of developing this, you say going into college, significantly increases this. What the difference is more speculation. The thought is that this may just be a higher intensity or more off-season workouts being required, since a lot of these deaths seem to happen in the off-season. But it does happen in high schools, however, it is less common.
Okay, Keisha Hampton asks, since the NCAA is screening athletes, do you think testing and training modifications should occur at the high school or middle school level? So you don't know of too many cases in high schools, but this is a good question because it's saying, should they be testing and screening or putting in these modifications at lower levels of competition?
Yeah, if we're doing that to mandate participation, I'm not sure I would go that strongly for that level. At that level, I think we should also be doing just universal precautions in general, just to kind of keep people interested and in active lifestyle. One of the big things I think about mostly for high school and middle school athletes, this has to be something that's very inclusive. If we think about things from a population standpoint, still at the end of the day, your biggest risk of death throughout your life is going to be complications of diabetes and heart disease. And kind of these young ages, getting people on these kind of lifestyle methods, this is very important to do. I do understand the idea. It's why would these athletes be different than, say, the college athletes? Kind of talking about how organizing the screening in the NCAA and all the different colleges is more difficult to manage, or as far as mandating a policy is more difficult to manage, just because you have multiple small organizations that you're working with. I just don't know if it could be effectively done. No one has really addressed this or looked into this, but it is a significantly lower risk population compared to the NCAA. And I just think what we do with the screening and how well these patients are counseled, I don't know if a lot of those athletic departments are going to have the personnel to really explain this well, to where this is well executed. Again, that is speculate. That's kind of my own opinion.
Okay. And we'll have, let's see, one more question. Derek Robertson again, he asked, you mentioned using ice baths to bring down a SCT athlete's temperature. Is there a risk of an ice bath intensifying the sickling event?
Intensifying the sickling event?
Yes.
Not that I'm aware of. The reason that I mentioned the ice baths, typically that's how we most effective way for treating heat stroke. So they did multiple studies where if you had people say, I think this is mostly studied with cross-country runners, but if you had people going down and then they were with a sport and then are transmitted to the hospital to be cooled off, depending on how long it takes for the ambulance to get there, how long it takes to get to where they're picking the kids up, but then also to drop them off at the hospital and then getting the IV started, that is time. And there's kind of saying time is tissue. So if you have someone who's at that heat, I mean, they're running out of tissue. So a lot of athletic departments already have some of these where they have ice baths. They have these kind of resources available. Do we have to cool them down with ice baths? I don't think you have to. I was more kind of referencing that you could use this as what resources you have available. But for decreasing body temperature quickly, ice bath has been shown to be the most effective. But again, that's not the main cause of what's going on with sickling. That'd be more of a heat stroke related problem. If we did just have cold cloths, getting pads off, and even just kind of the evaporation cooling like a mister, those would also be effective ways to do it. But as far as the ice baths exacerbating the sickle cell trait, I haven't seen anything.
Wonderful. All right, I don't see any more questions and we do need to move on, but certainly you did a great job and we appreciate it. And thank you for coming online with us today to participate in our very first ever virtual conference. Also, let me just state, and I kind of have to do this as an alumni of Notre Dame. I was really enjoying all of those pictures that you were showing of all my Notre Dame athletes. So thank you so much for that. But thank you. And if you give us control of our screen back, so stop sharing your screen.
All right.
And there we go. Again, we thank you so much. And I see that we're about ready to move on with Dr. Mary Hulihan coming up here in a moment. But thank you, Dr. Jaeger, and I look forward to meeting you in person someday, I hope.
Likewise. Have a good day.
Okay. Just a moment here, Mary. Got a couple things we've got to do if I can figure this out.
In 1992, local minority health coalitions throughout Indiana were inspired to start addressing the health disparities among Indiana residents. With the help of the Indiana Black Legislative Caucus, they collaborated to develop the first 5-year minority health strategic plan for Indiana. As a result, these local coalitions were able to create the Indiana Minority Health Coalition to facilitate the adoption of the strategic plan as it passed through the legislative process. Maintaining a healthy lifestyle is the key to ensuring that we all are able to live productive lives. With health and longevity, we're better able to make the most of our relationships with family and friends. However, we know it's difficult to adopt the healthy habits that help us minimize our risk for heart disease, obesity, diabetes, and other health conditions that can inhibit our ability to lead long, productive lives. That's why the Indiana Minority Health Coalition is dedicated to helping you. IMHC's programs, research, educational sessions, screenings, and more are at your service to ensure the best possible health for you and your family. For more information on IMHC, visit them online at imhc.org.
Dara can help you have fewer pain crises. In a 48-week clinical study, the frequency of pain crises was reduced. Also, giving patients fewer hospitalizations due to sickle cell pain decrease. In addition, Dara doesn't have any contraindication of black box warning, but the most common adverse reactions were constipation and headache. Speak with your healthcare professional to determine if prescribing Dara is right for you.
Hello, I'm Dr. Virginia Kane, Director and Chief Medical Officer of Marion County Public Health Department. I am here with two special friends, Alexandria and Audrey. Coronavirus or COVID-19 is real. It is affecting our community and our young people every day. It is important that you watch out for your loved ones and yourself. You hear a lot about me, but let me say, COVID-19 is real. Rise above the myth, elevate your mind, and choose life, not death. Life is the way to go. Think twice and act once. This is real. Remember to social distance yourself 6 feet. Stay at home. Wash your hands frequently. Cover your cough and sneeze. Clean and disinfect touched surfaces. Wear a mask in public. This is real. Remember, COVID-19 is real. Rise above the myths and reduce the spread.
Thank you for participating in the 2020 Indiana Sickle Cell Conference. And I am very, very happy that we are now getting ready to hear from the esteemed Dr. Mary Hulihan. Dr. Hulihan has been very active in research and study, promotion, advocacy, you name it, regarding sickle cell disease over, what is it, at least a decade or so now. And we are good friends with Dr. Hulihan, and we follow what she does very closely. And so very, very happy to have her join us today. Can you hear me okay, Dr. Hulihan?
I sure can. Thank you so much.
Great. I hope that you didn't have to wait too long before we were able to bring you on, so that's good.
Perfect.
But I really am happy that you're here with us, and I think that you're a good one to wrap up our conference today, because you've got the kind of information that tells people what we're really dealing with. We've been focusing a lot lately throughout the morning on issues related to sickle cell trait regarding health and how it affects your health and things like that. But you've got a different angle that we think is also important, in fact, very important. So I'm going to turn the floor over to you in a moment, but first let me introduce you to our audience. And if you don't mind, I'll do that. And then, of course, you can correct anything that I say is wrong, and I'll be okay with that. So Dr. Mary Hulihan is the health scientist at Centers for Disease Control and Prevention. She works on a CDC Foundation effort with CDC called the Sickle Cell Data Collection Program. Dr. Hulihan earned her Master of Public Health degree from the George Washington University in Washington, D.C., and her Doctorate of Public Health from the University of Georgia. She joined the Center for Disease Control and Prevention in 2008 and has served as project officer for the Registry and Surveillance System for Hemoglobinopathies and Public Health Research and Surveillance for Hemoglobinopathies. She is also serving as acting team leader for Red Cell and Iron Disorders team. Dr. Hulihan has written many research articles on sickle cell disease and sickle cell trait, and Dr. Hulihan knows her subject matter as well as anyone. We're honored to have Dr. Mary Hulihan on our panel today, and we're really looking forward to what she can tell us about sickle cell trait. Ladies and gentlemen, it is now my honor to introduce you to Dr. Mary Hulihan.
Thank you so much, Gary, and thank you so much for having me here today. Let me do this, sharing this. All right, is that looking okay for everyone?
Yes, we see it just fine.
Great, wonderful, then I will get going. So, and I do apologize, I haven't been able to, I caught about the last 20 minutes of Dr. Jaeger's presentation, but I wasn't here earlier today. I hope that I am not replaying information that has already been shared throughout the day, but what I really wanted to do is give you a little bit of historical perspective. I think that may underlie a lot of the topics that have been talked about today, certainly the issues with NCAA and sickle cell trait testing, and then go into some information that we do have about the US population, the incidence of sickle cell trait in the population based on data from newborn screening, and then also share some materials that we have available that are on the CDC website. They're free for everyone to use, and they were developed to really try and spread credible evidence-based information that was compiled by a group of many experts about sickle cell trait. So, and certainly at the end, if you have questions, I'm more than happy to entertain them. If I don't have the answer, I will do my best to find the information for you and get back to you via email or a phone call. So, all right. So, I think it's important to consider, I know you've heard a lot about newborn screening today, but to think about where we started and where we've come with screening for sickle cell disease and therefore for sickle cell trait. And certainly, as has probably already been mentioned, the real crux behind screening, hemoglobinopathy screening in newborns was to detect individuals with sickle cell disease. So you can see her here on the left. In 1975, New York was the first state to implement universal newborn screening. And there had certainly been some targeted newborn screening practices in states prior to that point, but it wasn't until 45 years ago that a state was universally screening all of the babies born in that. And then over the years, the number of states implementing universal screening for sickle cell disease certainly increased. You can see there in the middle, 20 years after New York began, you know, the relative majority of the states were screening all babies for sickle cell disease. And then by 2006, May 1st of 2006, in fact, the entire US was screening. And again, sickle cell disease, but if you have those results, you're getting the sickle cell trait results as well. And I think the important thing to consider is depending, and certainly only for children born in the US, but depending on which state you're born in, those newborn screening results may or may not be available. If you were born in New York and you're 45 years old or younger, chances are that you did receive a newborn screening test for sickle cell. But, you know, if you were born in that last state to implement screening, which was in 2006, it's only those individuals who are about 16 years or younger where those results would be available. And so, you know, talking about people having their results available, either when they're starting athletics or when they're starting in the military or other issues where their sickle cell trait status may be of relevance, considering which state they were born in is certainly something to take under consideration, and then also taking into consideration that just because a state started screening at a certain point does not mean that they have those results readily available or accessible. So again, that's just to kind of set the playing field of where we're going when we talk about access to screening results and things like that. So as a result, taking us back to December of 2009, as a result of all of the information around that time that was coming out, in particular about athletes and members of the military suffering complications of sickle cell trait and in some cases death, you know, the sickle cell community really wanted to make sure that people were coming together, having meetings, really discussing what the knowledge base was, what the general consensus was about implications, public health implications of sickle cell trait, and to make sure that there were statements put out so that the public as well as health policymakers were aware of what expert opinion or expert evidence said about all of these new rulings or mandates or what have you that were coming out. And so in December of 2009, the Sickle Cell Disease Association of America worked in conjunction with CDC to convene a meeting of these partners. This is a paper that was put out the following year in the American Journal of Preventive Medicine that kind of goes through who participated in that meeting and also what the outcomes of that meeting were. And so here are the conclusions that the attendees at that meeting came up with. They kind of fall into these 5 big buckets. First, looking at research in sickle cell trait. The consensus was there was a lack of research. There's a lack of evidence. There's a lack of systematic evaluation to really assess the risks of adverse health outcomes associated with sickle cell trait. The second area that those conclusions came under was communication, education, and awareness. The meeting attendees felt that there was a lack of consistency in content and delivery of health education messages about sickle cell trait, as well as a lack of public awareness regarding the health issues associated with trait. So this lack of consistency in content and delivery, you know, is really talking about that depending on which stakeholder group you may have been a part of, if you were a healthcare provider, if you were an athletic trainer, if you were a parent, if you were an individual with sickle cell trait, there was different messages going out and those messages were not always in agreement with each other. And how confusing is that if you're hearing something different than your doctor is hearing, or your parent is hearing something different than you are, so that there really, you know, the conclusion was there really needed to be consistency in that information. There were also conclusions about screening practices. Can you just do any sort of screening available for sickle cell trait? And the conclusion was no, you can't. That there really needed to only be reliable laboratory methods that were in use, and that those were what should be used for screening to support the appropriate individual education for all abnormal hemoglobins. And I say all abnormal hemoglobins because this testing and these laboratory methods can detect other forms of hemoglobin besides hemoglobin S. And so really making sure that the lab methods used were doing appropriate, adequate jobs. And then certainly the ethical and legal concerns that even there's concern that even in the context of organized sports, athletes with sickle cell trait could experience discrimination. There are also concerns that about who was providing that information to people with positive results. The group who met decided that only a physician or genetic counselor, that's really, they felt those are the only people well qualified and equipped to provide screening results and to communicate the health implications of having sickle cell trait to an individual, so that you can't just give someone their positive sickle cell trait result and walk away. There needed to be education. What does that mean for that individual themselves? What does that mean for that individual if they reach a point in their lives where they're deciding to have a family? Really, how can that impact all aspects of an individual's life? And then finally, there was the conclusion that there needed to be a lot more discussion about prevention of adverse health outcomes, that there was support for utilizing a universal precaution approach in training, similar to what the Department of Defense had done and what we just heard about in the last talk. Making sure that whatever was decided to be beneficial for those with sickle cell trait was implemented across the board for everyone, that everyone could benefit from these precautions. So again, that meeting took place in December, and then in January, so just a few short months later, that group provided a report during a workshop on carrier screening. And this report was given to the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children. That's a really long term, but basically the Secretary and the Secretary's Advisory Committee are the ones who decide, make decisions about what is included on newborn screening panels, what are the core conditions that are screened for, what are the additional conditions that may be screened for. And so really, they're kind of in that realm of newborn screening. And so SCGAA wanted to make sure that this group was aware of all of these different considerations. I won't go through each of these, but I think suffice it to say a lot of the information that came out of that December 2009 meeting was included in this report. So, I mean, my takeaway from that is you have a group of experts, they came together, they had a lot of really important discussions, they came up with conclusions, and those conclusions did not just sit on somebody's desk, but they were actually taken and used to inform decision makers about carrier screening. That took place in January of 2010, and then in September of 2010, this group was again invited back to that Secretary's Advisory Committee, and they were invited to share concerns about the rules and practices of screening college athletes for sickle cell trait. They were invited back to discuss the impact of the policies and practices. And they were, it wasn't just a come and tell us what you don't like. It was come, tell us what you don't like, and recommend how we can make it better. So really looking for ways to not just share concerns, but to share actionable ideas for moving things forward. And so that's what took place in September of 2010. So here were the recommendations then that came out of that advisory committee. So that advisory committee kind of took all of the information presented to them in the briefings, took other evidence that was available, and put together this group of, I believe it's 7 recommendations. So we can just kind of quickly walk through these, and they are all available in this PDF at the website at the top of your screen. So all individuals should have the opportunity to find out their risk for various medical disorders, including carrier status for genetic conditions as sickle cell disease. So basically that everyone should be able to find out if they do or do not have sickle cell trait. The Secretary's Advisory Committee recommendation was that genetic testing should not be a prerequisite for participation in sports, that evaluation and testing for sickle cell disease and other genetic conditions should take place within the individual's medical home. So within, with the guidance and with partnership of a medical provider. And that evaluation should not just include those screening results, but also include counseling regarding the implications of the information for that individual and the assurance of the privacy of their genetic information. And as part of evaluation for participation in organized sports, all potential athletes should be given education on safe practices for prevention of exercise and heat-related illness. So that's kind of getting at that whole idea of universal precautions. This is the end of those recommendations that athletic programs should apply universal precautions, and it should be kind of informed by those that are used for military recruits. There's the recommendation that the National Institutes of Health, or NIH, and CDC should conduct and support research to ascertain if some athletes with sickle cell trait are at increased risk of exercise-related sudden death. And that recommendation is really because the advisories committee, the information provided to them in their mind did not kind of reach that standard of there being enough evidence of the negative consequences of sickle cell trait in an athletic or military setting. And then the Secretary of Health and Human Services instructed this advisory committee to work with SCDAA, other federal agencies, athletic associations, community-based and healthcare professional organizations to develop guidelines and educational resources about screening for sickle cell trait in all persons, including athletes. So it wasn't kind of, I mean, my takeaway from these recommendations wasn't, here's the end all be all. It was, here's what we know at this time. We want more information. We will, you know, there is the opportunity to reassess at later times if and when more information, more evidence becomes available. Again, this was back in about 2010. And so I highlighted in red that last part because that's where I would say from the CDC perspective, the educational resources are kind of what we saw as our marching orders coming out of these, of all of these different meetings and briefings. And so CDC, the American Society of Hematology, the Sickle Cell Disease Association of America, those three groups partnered together to create a toolkit of materials about sickle cell trait. This took place over, I would say, about a 2-year period. There were kind of 3 main work groups for these educational materials. One was very healthcare provider focused. One was very athletic trainer or just sports trainer focused. And then one was more from kind of general information focused. And each of those work groups had representations from the clinical community, from the patient and family and community organization community, from the NCAA, people from the military were part of these work groups. And they all worked together to think about what questions need to be answered, what questions need to be answered that actually have information available for those answers, and what messages need to be put together so that all audiences, regardless of who they are receiving the same information. That information may be shared or packaged in different ways, but it all needs to be saying the same thing. So here is the website for these educational materials. There is information, again, for the general public. Get screened for sickle cell trait. There's fact sheets that have been created. There are materials for social media that have been created. And then on the right, just some really basic information about what is sickle cell trait, what are the genetics of sickle cell trait, how does inheritance of sickle cell trait work. So those kinds of materials. Then there's the much more comprehensive sickle cell trait toolkit. I should have looked, and I'm sorry I didn't do this. I would say there are probably between 20 and 25 different topics covered in this trait toolkit. So again, things from what is sickle cell trait to, as you can see here, what should you know about diabetes tests if you have sickle cell trait. There's information if you're an athletic trainer and one of your athletes has sickle cell trait, what does this mean for you? There's information about renal medullary carcinoma and its association with sickle cell trait. So across the board information, a lot of different audiences may benefit from this, and really try to create materials all based on peer-reviewed, published scientific evidence. The other thing that we took into consideration when creating this toolkit is that people who are affected by sickle cell trait, who have family members affected, may not all be English speaking. And so all of the materials are available in English as well as Spanish and French. This is all there. It can all be printed. It can all be downloaded. It can all be, downloaded and posted on somebody else's website. It is there. We want people to use it. We want people to learn more, be interested, and formulate their own questions after reading through this toolkit. Another way that we tried to provide educational materials is to do personal stories that are concerned with sickle cell trait. So we have a lot of stories about people, caregivers, families of those living with sickle cell disease. We have also incorporated some information and some, first person accounts from the sickle cell trait perspective. So on the left is a story that was written by a woman named Richie Johnson, who had an adult son, Chris, with sickle cell trait, who passed away due to his renal medullary carcinoma, and talking about, kind of her son's journey through life and some of his interactions with the healthcare system, maybe some factors that were present earlier in his life that could have been studied or taken into account a little more carefully. And really just, it's awareness raising. It's bringing attention to sickle cell trait. And some of it's, although probably very uncommon, but real comorbidities or co-associated conditions. And then on the right, there's also a story from Dr. Alvarez, who is a physician down at the University of Miami, who does both clinical research, laboratory research, and takes care of individuals living with sickle cell trait and with sickle cell disease. And so, and her real interest, area of interest has been this same kind of cancer that affected the gentleman on the left, Mr. Johnson. And so tried to give the perspective of what is a physician or any sort of healthcare provider looking at and thinking about when they're taking care of an individual with sickle cell trait. So again, all of these are available. I highly encourage you to take a look and to share these with whomever you think may be interested or might benefit. If you're looking at the toolkit and you think that there are areas of information that are really important that are missing from that toolkit, I encourage you to please get in touch with me. I think the one caveat is if something is going to be added to that, there really needs to be sound scientific evidence that can support and can be referenced for anything new that is developed. And so I'm just going to finish up today with a few more slides. I promised that I would talk, what do we know about the incidence of sickle cell trait, the incidence being new cases of sickle cell trait in the United States. So this is a paper that was written in MMWR, the same MMWR that is being talked about quite a bit these days in the news, but this was back in 2014. And so a report was written back then. This was a collaboration between CDC and the Association of Public Health Laboratories, or APHL. APHL is a group that works closely with all of the state newborn screening programs. And so we partnered with them to do a survey of the state newborn screening programs to try and get a better sense of how many babies were being born and receiving a positive sickle cell trait screen throughout the United States. And as far as I know, this was probably the first time this was done on a national level. It has not been repeated, but you can see it's been 10 years. And so maybe it's something that is worth repeating at some time in the near future to go out and redo this survey, and certainly something that we can consider. So of all the states, 88% responded, 44. And so the information I'm going to give you will be only about the responses from those 44 states. but you'll see we did a little bit of extrapolation to try and figure out what's going on in the entire US. So lots of information here, and this is all contained in that report. If you would like to go in and look it up for yourself, please feel free to do so. But basically what you see here is for all 44 of those states, how many infants do they screen through their newborn screening program every year? So, these babies are screened for every condition that is on that state's newborn screening list. How many infants had a positive sickle cell trait screening result in the year 2010? And then, just kind of merging those numbers together, what does that result as far as incidence per 1,000 babies screened? So of the 44 states that responded, there were a little over 55,000 babies with a positive result for sickle cell trait in that year. Again, since that's only 88% of the population, if you kind of do a little bit of basic arithmetic, that means there's probably about 60,000 babies born every year with sickle cell trait in the United States. And probably it comes as no surprise, there are some states that have very few babies with sickle cell trait, less than 50. And then at the other end of the spectrum, there's some states that have a lot, upwards of 5,000 positive babies every year. So, the number of positives certainly differs by state, but overall, the incidence in the United States is about 15.5 positive sickle cell trait screening results per 1,000 babies born. That means about 1.5% of all of the babies that were screened had sickle cell trait. This is all babies screened. This is not a particular racial group or ethnic group, but all babies born in the United States, about 1.5% have sickle cell trait. The lowest incidence takes place in Montana, and then the highest incidence takes place in Mississippi. We also asked the states to report their numbers by Hispanic ethnicity and by race. So of the 44 that we received information from, only 13 provided us that information with an ethnic and racial breakdown, but I'll show you what we have here. So we first asked about Hispanic ethnicity. In those 13 states that provided their information, overall, the incidence was about 6.9 per 1,000 Hispanic babies screened. So specifically in the Hispanic population, about 6.9 per 1,000. Now, I will say this has nothing to do with sickle cell or sickle cell trait or anything. This is just in general for newborn screening. Every state has its own protocol and every state does things different. And those things include how they determine race and ethnicity. So anecdotally, we know, we've heard from states, some states determine a baby's race and ethnicity by asking a parent. Some states, the person filling out the information on that newborn screening card determines race and ethnicity by looking at a baby. In some states, it's determined by the hospital where the baby is born, providing that information. So maybe a nurse makes that determination. So I'm giving you information about race and ethnicity, but I also want to make sure that you're clear that the way that is determined in newborn screening programs varies, and there are probably, various ways you can interpret that information by state. But I thought it was important to share this with you nonetheless. And then next, we'll look at race. So again, 13 states provided information about race. You can see here we have it for a few different racial categories. In the Asian, Native Hawaiian, or other Pacific Islander babies, the incidence is about 2.2 per 1,000 babies screened. In white babies, it's about 3 per 1,000 babies screened. And then in Black or African American babies, it's about 73 per 1,000 babies screened. So one really important message I would say here, again, with all the caveats of there being challenges about the ways race and ethnicity are collected, but certainly very important, there are babies of all different backgrounds, all different ancestries that are born with sickle cell trait. In these 13 states alone, about 20% of the babies were not Black or African American. And so when it comes time to educating the general public, when it comes time to educating healthcare providers, when it comes time to thinking about future family planning, I think that this is a really important message that needs to be distributed and disseminated and understood very, very widely. That sickle cell trait can affect everyone, and it is something that probably everyone needs to be aware of. And you know, as with those recommendations that I provided before, people being screened for sickle cell trait and knowing their own sickle cell trait status, you know, could be very important. So that's the information I wanted to share with you. I'm sure that you can tell there is a lot of future work to be done. There, with the information presented today, there are still a lot of gaps in our knowledge about sickle cell trait. Just a couple of studies that I do know that are taking place. I am fairly positive that in California, they recently received funding to use their newborn screening data, and they're going to link that up with, I believe, don't quote me on this, I might be a little incorrect. I know they're linking it with death records in the state. They may also be linking it with hospital data in the state to try and better understand what is going on with their sickle cell trait population. Of course, there's challenges with that. You only have people as old as when newborn screening for sickle cell trait started in California, which was very early 1990s. But the benefit is you actually have a laboratory result that you can use to identify individuals with sickle cell trait. So I would say stay tuned for the information that comes out of that study. And I think it just got funded, so it will be a while, but there should be some great information coming from there. I also know, I just recently saw an announcement that there is a fairly small, but possibly very informative study going on in Georgia, looking at individuals with sickle cell trait who have COVID-19, who screen positive for COVID-19, or who are hospitalized for it. So to try and get a better handle on whether there is any sort of association or relationship between sickle cell trait and COVID-19. In my thinking, the challenge about trying to make any conclusions from a study like that is it's kind of a snapshot of what happens at one point in time. And obviously there are so many other considerations in a person's life besides that they have sickle cell trait that could really come into play there. But hopefully that will start helping us to understand if there is any sort of relationship between sickle cell trait and outcomes for COVID-19. And as always, there is so much opportunity for awareness raising and education still to be done for the general public, for healthcare providers, for healthcare policymakers when it comes to sickle cell trait, and you know, probably a lot of conversations that need to be revisited and reassessed. So that is my information for today. Thank you so much.
Thank you, Dr. Hulihan. It's a pleasure. You did great, just like we wanted, and we appreciate all the information you gave us. I don't see any questions in the chat, but I have a question for you. You were talking about the MMWR study, and it was in 2010. What would it take to have that study get initiated again for 2020? And I think that there probably should be. When you see things that have taken place from our environment, we see so many more immigrants that have migrated into the United States from countries where sickle cell is prevalent. They're having children. That could have an impact on some of those numbers. So what would it take to get another study done?
Sure, great question. So this isn't thinking about like really from the CDC perspective. This is just kind of thinking from a global perspective right now. That those surveys were completed by public health departments, as I'm sure everyone can imagine right now. I'm not sure that this would take precedence of answering these surveys in public health departments at the moment. So I will say that I think the pandemic is probably, going to put a little bit of the brakes on this. That being said, I think this is a wonderful opportunity to repeat this project, to repeat this question. This is not something that takes a lot of funding and a lot of resources. Really what it took was, I would say the biggest time was just reaching out to the newborn screening programs and, encouraging them to provide this information, because they just have so much work going on, and this is kind of one more effort on their plate. But no, I think this is something that certainly could be repeated. I think this is something that, as you said, we could learn more information. We could learn from what happened when we did it last time, just procedurally, and think about ways to maybe do it a bit better. So I think it's a great idea, and I think it is something that is certainly on our list of things that we would like to participate in again. Possibly not right this moment, but hopefully in the not too distant future. So
understood.
Great thoughts.
Understood and agreed. My last question for you is, from your perspective, which is more of a huge global perspective, what is the most important thing that should be taking place right now with regards to sickle cell disease and sickle cell trait?
So those are probably, so please know I am not a clinician. I am not a healthcare provider. This is not from a clinical perspective. This is from a public health perspective. I think it's probably two different questions. I think for sickle cell trait, something that can be done is certainly education and general awareness raising. I can only imagine that this is true for everybody on the phone. When you tell somebody, either you work in the field of sickle cell or you have some connection to it, and you get the response of, oh, I didn't even know it was still around. So I mean, if that's the response, we're not doing our job of raising awareness. So I think that first and foremost is certainly something. I will tell you, I participated last year, and again, timing wise, it just is not at the top of everyone's radar right now because it was kind of toward the end of the year. But there was a large gathering of a lot of people from the military, from the NCAA, from organizations who have a lot at stake when it comes to sickle cell trait, that took place in Washington, D.C. last year. There was a lot of great conversation. I learned, I did not realize this, the United States military has an extremely rich database and biospecimen repository from people who are in the military, and there's a real opportunity there, I think, to do a lot more research when it comes to sickle cell trait. So those are kind of two areas that I think in sickle cell trait could really be further explored. And I will say there was a lot of strong support, strong interest, and I felt very personal stake from the people who attended that meeting of trying to get a better handle on what is happening. It was very impressive. It's sickle cell disease, I think it's a bit of a different question. Of course, education is still important. Of course, research is still important. I will say from CDC's perspective, our main focus these days is the surveillance system. So just trying to get a better understanding of who has sickle cell disease, where they live, where they receive their health care, that really fundamental foundational information about sickle cell that we still don't know the answer to. And as you probably know, Indiana is one of the states that we've been partnering for the last year and just received funding to continue that relationship moving forward. So that's really where our focus is. I think other federal agencies are focused on curative therapies and focused on clinical trials and focused on access to care. All I can say is there are so many conversations going on. There are a lot of meetings held. There is a lot of talk. And I think there is an attempt, I hope there is an attempt for there to be some collective, singular ideas coming forward so that everybody is on the same page.
Wonderful, Dr. Hulihan. Thank you so much for being with us today. We appreciate your time. We appreciate the work that you're doing. Thank you so much. If you'd give us control of our screen back by stop sharing your screen. Thank you so much. And have a great day. Have a great weekend. And we have met in person. I don't have to say that. I said that to some of the others that we haven't met yet. But you and I have met in person. I'm looking forward to seeing you again.
We've had lots of fun times together. So yes, looking forward to some more.
All right. Thank you. Have a great day. Okay. Well, we're just about to wrap up our session today. And I think it's been a great session so far. And we're glad that people have been able to join us. We're going to close out with a little bit more information for you. And to thank our sponsors, give them some airtime. No sound. We have a technical difficulty here. Well, we've lost our sound, unfortunately. I don't understand why, but we do want to thank our sponsors. Emmaus. We want to thank Global Blood Therapeutics. We want to thank the Marion County Public Health Department. We want to thank the Indiana Minority Health Coalition. We want to thank the Indiana Hemophilia and Thrombosis Center. Those are our key sponsors, and we want to thank everyone for being a part of our session today. We hope that it's been informative for you, and it's our honor to have had the opportunity to share this information. This is Martin Center Sickle Cell Initiative in Indianapolis, Indiana. We're signing off the 2020 Indiana Sickle Cell Conference, Sickle Cell Trait, taking a closer look. Thank you.
Great.